All right. Good morning to everybody. Let's do it. Today is neuro. That's our first topic of the day. Let's get situated here. And reclaim host. Neuro. Let's see where are we at. Here we go. That's neuromuscular. Ah, there we go. Neurophysiology. You ready to have a page for neurophysiology?
Yes.
722. So everybody online, just so you know where you should be. 722. We are ready to roll. All right, just take a look, see if anybody else is standing out there. Just let them know we're about to start. Ooh, one of those cold mornings, man. Cold. Huh? Nah, but I got like 3-4 layers, but I don't be playing. When you live in Central Illinois, you better know how to layer it up, boy. Got one of those Canadian Downs. Oh, yeah, Canada Goose. I don't feel a thing when I put that thing on. Yeah. You know what? No, you know what? My wife is one that got me addicted to shopping. So the key is to know where to go and what time of the year to go. Oh man, I'm always looking at clearance rack. I don't go to the pay full price stuff. Yeah. The Canadian Down, I got it at a store right here in Champaign. It's called City Trends. You know, just got a lot of different clothes. I walk in and I see this Canadian Down. I said, wait a minute, they got Canadian Down? This is there's like a TJ Maxx, you know, marked down from the high prices. I said, there's no way they got Canadian Down. It was the only one on the wall. I said, I looked at the price tag, $50. I said, no way. I said, do they know how much this thing is worth? I said, well, shoot, I'm glad they don't, because I got it now. This is mine. I mean, when I walked out, I think first time I walked up, I can't remember where I was. Somebody said, man, where you get $1,000 coat from? I said, well, you know, yeah, right. I didn't tell I got $50. Holy, I don't think that store even knew how much that coat was worth. They just put $50 price tag on it. Man, the Lord was on my side. I happened to walk in that day, boy, $50 for Canadian Down. Man, and folks were telling me they were paying $800, $1,000, $1,200. I said, okay, well, good luck to you. I got about $50, man. They couldn't believe it. Oh my goodness. All right, let's go ahead and start. Let's see. Somebody got a statement. 5 degrees in New York, huh? Woo, my goodness. And here we're complaining. Yeah, okay. At least we're like 18 degrees or something like that. So, all right, neurophys. We're gonna organize our knowledge in neurophys. I'm all about organization, folks. It's not about knowing everything, just like biostats yesterday. It's not about knowing everything. It's about organizing yourself. Yes, Sabu. Yeah, tell them that what's that cinnamon square, whatever that's called. Yeah. The coffee cake, yeah, the cinnamon coffee cake. No coffee. I'm not a coffee cake. Fondue. No, they ain't got no fondue. That's okay. Now, I'm trying to drink more water. I've had too many stones, man. I don't want any more stones. The pain of those stones is what keeps me focused on that water every day. Keep drinking that water. I don't want another stone. Oh my goodness, it's so painful when you get a kidney stone, man. All right, you guys ready? Let's do it. All right, you ready, Mabel? We gotta make sure Mabel is ready. You know we love you, Mabel. Yes, I want to make sure your sound is working. Okay.
I love you more.
Oh, okay.
I love all of you more, though.
All right, thank you very much, Mabel. All right, here we go. How to organize neuro, okay? It goes like this. We're gonna start from embryo, just like everything else. Embryo, start from the beginning, bring it all the way to physiology. Embryology of the brain. The brain is the first organ that it's said a million times. Hopefully you never forget that. The brain forms by 8 weeks. The baby already has a brain. Why? Because the brain controls everything else that's going to be forming. So it makes sense. He better form first. Okay. Here's how it starts. You start out with a primitive streak. You just see a line. All of a sudden you get a nodal cord. That's going to be who then becomes your spinal cord. Primitive streak to nodal cord to spinal cord. All right. In the first trimester, nodal cord is built by 3 weeks, and the brain is fully formed by 8 weeks. Then every other organ develops. Who's after the brain, Bailey? No, all right. Who's after that, Bailey? Okay, you guys know the drill. All right. So brain is active early with movements. Remember, the baby's moving automatically. That's autonomics. The brain controls that. Okay. The baby's swallowing in utero. That's autonomics too. Well, the brain has to control that. Okay. And so the brain is active in the formation of amniotic fluid, which we mentioned before. So let's go through it one more time. Amniotic fluid is a filter to mom's plasma. I said mom donates 90%, but the baby, Mitchell, swallows away 10%. That means you got to have a brain that works, you got to have autonomics that work, your muscles to the esophagus got to work, and the upper GI cannot be obstructed, or you cannot be hypothyroid where nothing's working. Remember, that's my 5 categories. If I see polyhydramnios. Okay, that's what I want you to be able to think things through. Don't just memorize a bunch of stuff. Once you think it through, you say, oh, it's got to be this, aha, and then you look on the list, there's only one answer. That's how, once somebody helped me to figure this out with Dr. Shah, I said, holy God, this is really what they're testing. Who's organized? Not who's read every book, knows everything, and memorized every detail, because then you won't see there's only one that's on this list. All right, because your mind is all over the place. Whereas if you organize yourself, so, oh, I only need this, this, or this, you look, there's only one answer. That's how I know that. That's why I congratulate you. That means you're organized. All right, so that's 80%. The fetus subtracts by swallowing the fluid, and then he must absorb and digest it. Then he takes that 10% that he drank and then adds his own 10%, which is just debris, venous fluid, and then urinates it into the sac. So that means the baby donates 20, the mom donates 80. Any questions on that? All right. Amniotic fluid. Before we do polyhydramnios, I told you amniotic fluid has 2 actions. Number 1, shock absorbent for the baby. Remember I told you mom's belly comes around the corner before she does. So she's always knocking into things. So the baby actually felt all the trauma. He'd be bruised up like crazy when he came out. But because that amniotic fluid forms a barrier all around him, when you hit a bowl of Jell-O, you see the ripples go through the Jell-O, but that egg in the middle does not fall at all. That's the baby's the egg in the middle. All right. So all the trauma is absorbed away from him. Second, amniotic fluid absorbs atmospheric pressure away from the baby. Why? Because we need his lungs to expand. You cannot expand a balloon into positive pressure. Because remember, you need a vacuum for a balloon to expand. Well, you can't have that if you don't have amniotic fluid. All right. So now, polyhydramnios, the 5 things I just told you about. See that? Neuromuscular. That means all the way from folate not there, neurotube defect. Okay. So autonomics, Bradley Day, you've heard that several times. Everybody should know that now. Muscle disease, Werner Hoffman, you've heard that a bunch of times. And then hypothyroidism, okay? Or that you got GI obstruction. What's the most common cause of hypothyroidism in a newborn? Cynthia Moreno.
Good morning, Dr. Francis.
Good morning, Cynthia.
I think it's agenesis or dysgenesis.
There you go, good job. All right, we're gonna be rehearsing as we go, folks, as always. Be on your toes. All right, GI obstruction, we got esophageal atresia and duodenal atresia. I just need a clue for esophageal atresia. Syed Zakaria.
So if they vomit, I guess.
No, vomiting can be a lot of different reasons. Give me a few more words.
Oh, like drooling.
Drooling since when?
Since birth.
Yeah, remember the kid can't even swallow his own spit. So he's been drooling since birth. He vomits his very first feeding because he can't go down. When you put a nasogastric tube down, remember, it curls and comes right back up at you. That's how you know you hit a wall. Okay? All right, you do a gastrographin, you can see the pocket, send them to surgery, cut the pocket out. If they ask you why that membrane is still there, Syed, what fail to happen? Syed, you still there?
Yeah, I am sorry. Just I'm blacking out a little bit. I'm assuming it failed to yeah.
No problem. Adnan will help you out. What failed to happen? Apoptosis didn't happen. Don't forget that, Syed. Every atresia, same answer.
Right.
All right, that's the easy points, man. All right, so Duodenal atresia, I just need a clue. Ida. Double bubble sign. This one will be bilious vomiting. Remember, 30 to 40 minutes after the first feeding, because you can't get past that membrane. And then double bubble sign when you do the x-ray. All right. Again, we send them to surgery. And, you can do barium, not barium, no, gastrographic study if you want. And you'll see the membrane, send them to surgery, cut the membrane down, it's cured. But the key thing is correct the electrolytes before you take them to surgery. Because if you've been vomiting a whole lot, Maria knows, if I check your sodium, it's gonna be what? If you've been vomiting a whole lot and I check your sodium, it's gonna be what? Low chloride, low potassium, low calcium, low pH. What? Hi. Okay, I was like, hi. How many syllables are in high? Good Lord, that's about 8 syllables in there. See, when you guys said this, I told you, I get scared because if you, I'm telling you, on day of exam, you got to make it automatic by the day of the exam. Click, move, click, move, click, move, click, move. Why? Because you're going through a process. The brain knows what you're doing. It stays nice and calm. Just look for the clue and click. Sees the clue, click. Sees the clue, click. If you hesitate, you say, hey, wait, brain, why don't you see something else? That's when you start reading the other stuff. And now you're putting those thoughts in your head. Those sentences are carefully chosen to create doubt because there's overlap. That's what I'm telling you. By avoiding them, all of a sudden my score stayed high. Why? Because I don't read most of them. I just look for that keyword, just like I showed you guys in the morning. Keyword, oh, right there, get out. Because if you're blessed and they give you a keyword, man, that's a freebie where I come from. I just click, I don't even want to read that. I don't even read that sentence because I saw the keyword, that's it. I said, there's no way the other answer can be better than this one, okay? All right, so anyway, let's do it in the treason. All right, Muhammad Khan, you have a question?
No, actually, sorry.
Oh, okay, no problem. All right, so oligohydro, oh, wait a minute, forgot to give you complications. With polyhydramnios, what's the main complication? Number 1, preterm delivery. Why is that, Ida? It's distending the uterus. Remember, that's a signal for first muscle contraction, and that means labor. So preterm labor, number 1 problem, over 90% of the time. Number 2, rare, but it does happen. Uterine rupture. I mean, obviously, that's the extreme. All right. So, Lawrence, you had a question.
Yeah, when we say treatment, is it that the entire complicated form or that there's
Good point. Yeah, when we see atresia, does it mean everything from that point on to inform? No, it's just there's a membrane. It's just like a membrane never melted down. We don't even know why. The rest of the GI is open. Yeah.
I thought we have to like create.
No, it's just one little, one little pouch there. Yeah, you just cut that pouch, we're done. Yep. All right, so polyhydramnios, preterm labor is number 1 complication. Uterine rupture is number 2. How do you know uterine rupture? The woman would be in labor. I mean, she's pushing, all of a sudden you see blood all over the place. And when that happens, her vitals crash. And then when you feel her uterus, watch my hand, or you feel, oh, wait a minute, I don't want to see it. Yeah, they can see me. All right, so you feel the uterus, when you examine the belly, you can feel a smooth contour and the head of the baby. On the test, they always say, you feel an abnormal, they're just hinting at it. You feel the uterus should be a nice contour. There should be no abnormal humps to it. So every time I see the question, they always kind of just hint at it without telling you, that's the baby's head you just felt. Okay? Should be a nice smooth contour all the way around. And instead I feel a bump. That baby just popped out of there. Another clue, they'll tell you what station the baby was at when the labor started. So let's say the baby was down to -1. And then all of a sudden after all that, back up to +2. That's how I know. See that? That means he popped back up. That means the uterus ruptured. All right, move fast because you got about 6 minutes to save both of them. So we always save the baby first because mom wants her baby saved. And then mom is one that's at risk because she's second. And so sometimes we don't get a chance to save her. Okay, but that's why you got to move real fast. You cannot waste any time. Okay, get that baby out of here as quickly as you can. I mean, that means you got to do C-section right away. Cut her open, get the baby out, and then, hope that you can still save mom.
Excuse me,
All right.
I remember my question.
Who's speaking?
Mohammed.
Is this Muhammad?
Yes, sir.
Oh, okay. All right, good. Go ahead.
Sir, is that the ordinary atresia related with projectile vomiting?
We can barely make out what you're saying. Get closer to your mic.
Does duodenal atresia have a connection with projectile vomiting?
Thanks, man. Does duodenal atresia do what?
Have a connection with projectile vomiting?
No, no projectile vomit. Okay, that's what he's asking. Does he have projectile vomit? The answer is no. Not like pyloric stenosis. It's gonna let me.
Oh, okay. Thank you.
Yeah. No projectile vomit. Only pyloric stenosis has projectile vomiting. Yeah, good question. They just say forceful vomiting or, bilious vomiting, but I've never seen them say projectile. Okay? All right, that's poly. Oligohydramnios says you don't have enough amniotic fluid. Remember the system we use for amniotic fluid evaluation is an 8 to 24 span now. It used to be 5 to 15. And the numbers we're talking about is hundreds of cc's. So 800 cc's, 2400 cc's. Okay? So that means if you're less than 800 cc's in each quadrant, that's oligohydramnios. Okay? If you're more than 2400 cc's per quadrant, okay, that's polyhydramnios. Now with oligohydramnios, you say, okay, how do I get my differential? Your problem is in the kidney, bladder, or you're obstructed. That means you didn't develop a kidney, you didn't develop a bladder, or everything felt fine, but there's obstruction in the way. Okay, that's how you talk it out so you remember the information again. Look at renal agenesis. There is no kidney because there's no metanephros. Without a metanephros, there'll be no kidney. The kidney proper, i.e. metanephros, goes as far as the distal convoluted tubule. Everything after that came from the ureteric bud. That means collecting duct, major minor calyces, papillae, hilum, ureter. All that came from ureteric bud. But you have to know that the ureteric bud must make contact with the metanephros or else there still is no kidney. So 2 ways to get renal agenesis. Either no metanephros or no contact between ureteric bud and metanephros. In San Rene? In San Andres? All right. Now, if everything develops normally and you still have oligo, then that means there's obstruction. Most common cause, PUV, posterior urethral valves. Question I know. Which people? Renal agenesis? No, they don't die in utero. Remember I said with oligohydramnios? If you have oligohydramnios, anytime after 24 weeks, what do? Immediate C-section, get them out. They used to die. I mean, they were almost dead. So and when they were delivered, was 100%, they die right after you deliver them. That's why they did that regression study I told you guys about. And they said, well, you have a 50-50 chance of living if we deliver you at 24 weeks. That's okay, that's what we're gonna do from now on. That's now the protocol. Anytime you see oligohydramnios, 24 weeks or greater, you got to know the answer is get that baby out now. Because it's like a rocket sitting on him. And that's the way you got to imagine it. He's suffocating. So there's no reason to wait till tomorrow or wait for an hour from now. It says emergency C-section. Okay? All right, posterior urethral valves. Because posterior urethral valves is so common, Amy, an enlarged bladder is therefore the most common cause of an abdominal mass in a newborn. Remember, and we did that little clue I gave you guys. Neuroblastoma does not start after a month. The first month, enlarged bladder is the #1 abdominal mass. Okay? And anytime you have an obstruction, what's the first thing you ought to do for it, Sandra? You have an obstruction in urinary tract, first thing you ought to do is do what? Any idea? And so let's ask Lawrence. No, not surgery right away. Anytime you have an obstruction in the urinary tract, the first step in your management, that's what they always say, put a catheter in there, get all the urine out of there. Why? That urine has been collected for 9 months. The bladder is humongous, way up here, almost a Simpson's pubis. That means it's smashing his kidneys. You're hoping he still has some renal function left. Because a lot of them, there's no renal function left. It just got smashed. So that's why they say immediately put a catheter in there, drain the fluid out. Usually 700, 800, 900 cc's of urine. That's a ton. But that's because he's been holding it for 9 months. All right. And then hopefully the kidney function works. That means you evaluate the kidney, BUN, creatinine, all that. And then you take them straight to surgery. Okay. And fix those valves. Get the urologist right away. All right. Potter syndrome is when oligohydramnios, Angie, causes a pressure effect on the fetus. So when he's born, you see the pressure effect. his lungs didn't inflate. So pulmonary hyperplasia or aplasia, it just didn't inflate. But besides that, the flattening of his faces, his forehead is flat, nose is flat, jaw is flat, chest is flat, everything's flat. Potter syndrome or Potter sequence. Any questions on that? The unfortunate problem is with Potters, that means if he was not caught before he was delivered, no, you can do it. He's gonna die. You can't do a lung transplant on a newborn. Okay, so that's Potters. Now, into the spinal cord. Any questions before I go into the spinal cord? All right, here we go. Spinal cord develops a notochord, like we already said. Your spinal cord goes down as far as L1, L2. L1, L2 begins right at the iliac crest. L1, L2 dermatome is your hip. Just to be complete, L3, L4 is your knee. L5 is your big toe. S1 is your Achilles. So you go out to the toes and then come back behind it. So Achilles is S1. Then there's a band of skin from the Achilles up to the buttocks, S2. And then you have 3 circles around your anus. Big circle, S3, medium circle, S4, tiny circle, S5. So we're gonna use it a lot. That's why I thought, let me give it to you now. It's anatomy, and if you look at the pictures, you'll see them, but we're about to go through a lot of diseases that involve these dermatomes. All right, L1, L2, iliac crest. Your spinal cord ends in a cone shape, which we call conus medullaris. And the conus medullaris, Ida, is S4 and S5 dermatome. Somebody's hand was just down. Dan, who just had their hand up? Somebody, was that you, Mohammed?
Okay,
Mabel?
that
Oh,
was
Mabel?
me.
Yeah, what's your question?
So please, I didn't understand what you just said about L1, L2, the organs you called, like the structures behind it.
What? All I did was
didn't-
give you where, no, hang on, Mabel. All I did was give you where you find the dermatomes on your body. That's just anatomy. That's memorization. L1,
Yeah,
L2 is your hip. Did you catch that?
Okay,
Where's L3,
Yes.
L4?
is it the sacrum or the,
No,
don't
it's
know.
your knee. That's what I'm telling you. I think that her sound system's not working, or she's gotta have songs. I mean, I'm not sure, but as soon as I ask, as soon as I
Okay,
explain something, correct what
okay,
she
I'm
asked me,
I'm
that means
okay,
she's not
sir.
hearing it.
I'm
Okay,
good.
no, I want to
I'm
make sure
good.
you hear it. No, I want to make sure you understand it. Make sure you're listening, because I'm not sure if it's your sound or what, because I just went through the whole thing. L1, L2 is your hip. L3, L4 is your knee. So all you have to do is just write one word down. All right, L5 is your big toe. S1 is Achilles. S2 is a band of skin from Achilles to your buttocks, and S3, 4, 5 are 3 circles around your anus. That's what I've given you so far. Did you understand that, Mabel? That part is
Yes, sir.
memorization. And that's why I said 2 weeks before your exam, spend 4 hours looking at anatomy pictures, 1 week before your exam, 4 hours again. Just so you have a picture of this. I mean, this one I'm sharing with you because I'm about to use it in all these diseases where I'm about to teach you. All right, so
Okay,
I want
thank
you to know it, okay? Yes, Michael.
With respect to Mabel, two suggestions come to mind as I
Mhm.
hear this. One, maybe she needs some headphones.
Oh, the headphones?
She doesn't have headphones on.
Yeah, Mabel, somebody suggested, you got headphones? Maybe that would cancel out noise around you?
Might help. And,
I should use headphones, right?
Yeah, because the headphones will cancel all the noise around you. Because maybe
Okay,
that's what's
all right.
interfering with the sound.
All right, okay, thank you.
Second suggestion I have might be that if she has the book open, she can follow along with the book.
Yeah.
Maybe she doesn't.
Oh, yeah. Mabel, do you have a book or the PowerPoint for the lecture?
Yes, okay, I have it.
Yeah, okay, yeah, because that way you just follow along. That way you don't have to write that much. I only add a few things as we go to update you, but most of it is right in front of you. That way you
Okay,
just
thank
follow along with me.
Oh,
724 is where we're at, so you know where all these things are.
thank
Okay?
you, everyone, yeah.
All right, good. All right, so now conus medullaris, we just said it's S4, S5. Nerves come off to the sides as what we call a cauda equina. That means when you look at a horse from the back, the tail, all the hair comes off like this. That's the same thing. And you're from L1 down to S5, the nerves come off to the side. Let's go through the whole spinal cord though. From C1 down to C7, the top, the nerve comes out above you. Top, above. That's how I remember it. Okay? That means if I slide backwards, my nerve is right behind me. I smash my own nerve. But C1, C7, that slides backwards, crushes its own nerve. Because that's the nerve that fell behind them. Everybody picture what I'm explaining. Okay? Because they'll talk about disc herniations and ask you what nerve will be compressed by this disc herniation. C1 through C7, your nerve is right above you. That means it drapes behind you. That means if you slide backwards, you crush your own nerve. Okay? C8 down to T12, your nerve is beneath you. So that means if I slide backwards, I'm actually crushing the nerve of the vertebra above me. Not yours, the guy above you. So totally different presentation for those disc herniations. Okay, this happens during car accidents and stuff. This is how you can tell which nerve is being compressed. If you see a disc herniation on an x-ray, you can tell exactly what nerve is gonna have problems. Question, Maria? One more time, the C8 through T12, your nerve is beneath you. That means your nerve drapes behind the one below you. That means if I slide backwards, is the nerve of the one above me that's draping behind me. That's when I'm gonna be crushing. So if I'm T7 and I slide backwards, I'm actually smashing T6's nerve. Okay, and then from L1 down to S5, beside. If it's beside, does everybody understand? If you have a disc herniation that slides backwards, asymptomatic. There's no nerve behind it. See, that's why they want you to know that. When somebody has sciatica, it means the nerve disc herniation is sideways. That's the only way you're going to crush these nerves. So that way, when they ask you a question like that and then give you the answers, you got to make sure you pick the answer carefully. Posterior disc herniation, and then you just missed the question. It's got to be a lateral disc herniation when you're talking about from L1 down to S5. Okay? All right. You understand that, Mabel?
Yes, sir.
All right, good. So again, one more time. C1 down to C7, your nerve is above you, so you crush your own nerve if you slide backwards. Because those can't slide to the side anyway. All right, C8 down to T12, your nerve is beneath you, so you're crushing the nerve of the vertebra on top of you. So the number before you, okay? Whereas from L1 down, you have to slide laterally to crush a nerve. Okay, all right. Filum terminalis is a tip of tissue that anchors the tip of the conus medullaris to the base of the spinal cord. Now, that brings us to osteoarthritis. Why am I talking about osteoarthritis here? Now, we know I do the disease as we go. I just found it much easier to understand. Osteoarthritis is the most common arthritis in everybody. Why? Because we're all going to get it with aging. Osteoarthritis is wear and tear of your cartilage. And as long as you live, you're going to wear and tear your cartilage. But what they like to ask is what's the most common joint involvement in osteoarthritis? And what do most students pick? The knee. Why? Because that's the one the book discussed. But that's not the answer. If you understand mechanical trauma, your lower back has trauma on it, even in utero. See? This is why they want physicians to know how to think for themselves, because otherwise everybody quotes the book. Now realizing the book didn't say that was the most common, you just thought it was. The book just spends time talking about where they saw damage. And it's just the knee is a big joint, so they saw damage, or the hip is a big joint, so they talk about those. But lower back is number one, which is why back pain is the #1 medical problem worldwide. Everybody understand that? Because everybody's gonna get it as you age, okay? Some will get more, some will get less, but everybody has back pain as they age because that's the first joint that's gonna be worn out. Then from there, go down the axis, hips, knee, ankle. That's how you do it. Okay, that way you don't have to memorize any of it. Okay, just think of what the disease is about. The physiology is wear and tear. Okay, now I can see the answers. Okay, that means I don't have to memorize and try to remember what a book told me years ago. All right, so osteoarthritis, non-inflammatory arthritis. So when it starts, it's wear and tear of the cartilage. What do you see on x-ray? Joint narrowing. Does that make sense, everybody? Because your cartilage is shrinking. All right, joint space narrowing. That means when it first starts, there's no inflammation. It's just wear and tear cartilage. Everybody understand that? You understand? There we go. That's why to treat it, we start out with acetaminophen because there's no inflammation going on. So anti-inflammatories are not necessary, and they burn a hole in your stomach. That's why they said acetaminophen is the first drug you start with. That was a study from way back. All right. And then when you go to NSAIDs, it's only because the cartilage has been totally worn away and now the bone is scraping off bone or with every step. See? Then it becomes inflammatory late in the disease. That's when we use NSAIDs. And for NSAIDs, they want you to use topical NSAIDs. That way it's not absorbed in the system. We don't want any burned bellies. And who are the topical NSAIDs? Who remembers that, Jess? Okay, one of them starts with a D. I just need to hear the rest of the name. Oxane, diclofenac, or ketoprofen, were the two I've given you. Now, again, that makes sense. Voltaren is a big one they're advertising all the time. Okay, so that's why you got to understand. It does not cross the stratum corneum. You don't have to worry about it going into the system. We don't have to worry about gastritis and gastric ulcers. So they want you to start with those. That way they just rub it on the knee or rub it on the shoulder, wherever it hurts, just rub it on there. Okay, it'll take away the pain, but doesn't get absorbed into the system. Okay, yes. Ketoprofen and diclofenac. All right. Yes, James.
Are the topical NSAIDs protective for like,
Yeah, they're protective because they don't get absorbed into the system, so they don't do any damage to your kidneys either. Yeah. So it makes sense. When I saw that new recommendation, oh, that makes sense. See, again, that's why I'm giving you guys the information at the most basic level. That way, when they come up with a complex recommendation, your brain will make the connection. Oh, I see why we're doing that. Okay. Let me see. There was one I figured out this morning. Hang on a second. I was listening to a CD. Let me think. What was it? Oh, yeah, here it is. They said a high salt diet causes kidney stones. I had to pause for a second until I figured it out. Otherwise, that means I gotta go look that up. Anybody think they can figure it out? How does a high salt diet cause kidney stones? Anders. How does it cause dehydration? It's gonna pull the water. Oh, Miss Anders, look at you. Yeah, I've seen that statement twice. Because the first time I said, I don't get this one. And I thought, well, I'll look it up later on. And then I'm listening to CD, they say it again. I said, okay, that means I got to figure this out. And then I thought about it. Oh, the salt is just holding on to water. That means less is getting to your kidney. Bam, I'm done. See, because now I made it part of what I already understand. Versus, oh, I got to go pull the article so I can see, oh, high salt diets now cause kidney stones. And at the end, they tell you the same thing I just forgot in 10 seconds. That's why I want you guys to learn normal before you start reading any pathology. You'll understand more pathology so much faster because you actually understand normal first than if you just read a whole bunch of diseases. Cares.
my mom had osteoarthritis.
Her mom has osteoarthritis of the knee.
Does
Okay.
that it like triggers it. So
Every
I
time she eats
had
spicy
to
food, it
figure
triggers it
out,
up.
Well, maybe it's inflammatory. The spicy food is like a.
Yeah, the spicy food has inflammatory agents in it. Yeah, that's just what's making it work. Dr. Bauman. Yeah, if it was uric acid, then eating meat would make it worse. So you got to send your mama a bill for $60.
Oh, I'm so.
Oh, yeah, yeah. Hey, mama, ain't no free consults right here now. You know, our family be calling you all the time. I know. Every family wants a free consult every time. Hey, Francis. And they start running a whole medical history past me. And I'm supposed to tell them everything to do about it. Anyway, that's family. That's good though. All right, Karina, go ahead.
Oh, it was just interesting that you mentioned that because yesterday's Stanford put out, they're doing a big research on like a new way to use pain meds instead of opiates, and they're looking at what's the stuff that makes spicy food.
Capsaicin?
They're looking at that to be able to maybe block it because chickens
Mhm.
can eat spicy food and they don't feel it at all. So they're looking at like their receptors and capsaicin.
Wow, so chickens can eat spicy food and don't feel any.
Yeah, so
Any
they're, like,
burn at
studying
all.
the receptor of it, 'cause they might use it in like surgeries and whatnot to not have.
Wow, that's pretty neat. Didn't figure that out. All right, anyway, here we go. Joint space narrowing is the cardinal finding on X-ray. Nobody should ever miss that. Most common joint involvement, again, lumbar vertebra, then the hips, then the knees, and all the way down to your ankles. This is one of only 2 types of arthritis. Remember, psoriasis being the other that affects the DIPs. Remember, anytime they say DIP, I told you when we did psoriasis, that's called a gift. Because I only got 2 things I got to consider. DIP, Everybody attacks PIP. I just skip right past that because that doesn't tell me anything. But DIP, oh, it narrows it down to 2. And that's it. Because every time I look down, there's only one of them on the list. All right, so remember that. All right. DIP, remember Bouchard's before Heberden's, going out that way. BH, all right? Bouchard's and Heberden's nose is just involvement of PIPs than DIPs. Sorry. Spinal stenosis is the next disease. Spinal stenosis, number 1 cause is osteoarthritis, which is why we just went through it. All these diseases have to do, osteoarthritis is number 1 cause because they're all in the lumbar area. Spinal stenosis says the osteophytes that are produced by osteoarthritis now start poking inward into your spinal cord. That means now you got a narrow canal because the osteophyte is taking up half the space now. How do you know this? Because when a person walks uphill or upstairs, remember when you're walking uphill or upstairs, you're leaning back some, okay? Whenever you do that, you squash the bottom of your spinal cord. All of a sudden, it compresses all the nerves and your legs get weak. Then at the top of the stairs, all of a sudden you sit down to rest. That's why they call it pseudoclaudication, because it sounds like claudication. When they're walking upstairs, exertion, oh, my legs get weak, so I sit down to rest. What you have to ask them, is there any particular body position that makes you feel better? They say, yeah, doc, I just gotta lean forward. Everybody see what you're doing when you lean forward? Separating it out again like this. When you lean forward, your lumbar vertebrae separate. All of a sudden, spinal stenosis is gone because osteophyte slides beneath. And then when you start walking upstairs, it goes back up and compresses again. All right? So lower extremities become weak after climbing uphill or stairs. Pain resolves or improves when they rest and lean forward. Treatment and physical therapy, surgery is last resort. Because again, because it's just so common, you don't want to be doing surgery on every old person that comes to see you. Physical therapy did pretty good. I think majority, over 90%, didn't have to go to surgery. Surgery is only a last resort. Yes.
But if it is also fine, they're coming in the same how.
No, physical therapy means, okay, let's say that level is here. What you do is strengthen the muscles above it so it pulls the spinal cord up like that. That way the compression site now is above where the compression would have been. Because remember, the spinal cord gets thinner as you go down, and then the compression is gone. Yeah, pretty ingenious whoever thought that up. Because one study I reviewed, something like 98% of them who are going to go to surgery didn't have to go to surgery, just with physical therapy alone. Anyway, but that's how we take care of it. Leslie, you have a question?
Yes, doctor. I have a question regarding the surgery.
Okay.
Like, my mom had this and she went to surgery and the doctor just cut the
osteophytes?
Yeah, so release the pressure of the nerve.
Right.
How they do that?
Well, that obviously that's more expansive surgery because you got to go into the spinal cord to do that. See, that's what I'm saying. That's what we used to do. Either go in there and shave the osteophyte off, or go in there and fuse the two that are together so that way there's no one sliding up and down. Ooh.
That was with laser. He did it with laser.
Oh, he did it with laser. Oh boy, that's
yeah,
new.
But it was really small, incision, you don't see anything
Yeah. Wow, I didn't even know they were using laser for shaving osteophytes. That's pretty. Is that right?
Yeah.
Oh wow, I didn't know that. See, there it is. Medicine's progressing. Yeah, because that used to be major surgery when I was out, and man, you see people they hated it because they were so stiff they could barely move. Yeah, so people didn't like it. Yeah, with laser surgery, I don't have to fuse anything. Okay, and it makes sense. If they figured out how to do that, that's wonderful. All right, so anyway, physical therapy is the treatment, just so everybody knows. All right, next disease, Cauda-Equina syndrome. How do I know you got Cauda-Equina syndrome? Cauda-Equina involves which nerve roots, Ashley? What? No, it involves L1 through S5, the whole thing that I described in the beginning, L1 through S5. And so L1, remember, starts at your hip. That's how you know you're gonna lose everything from the hip down. They call it saddle anesthesia because the part of you that sits on the saddle is your whole lower extremity from the hip down. Saddle anesthesia is the key clue for this Cauda-Equina syndrome. Now, anytime you have nerve compression, because this is nerve compression, what do? Number one, you give them steroids right away to shrink the swelling around that nerve. Because remember, you got to take the pressure off this nerve or else it'll die. That means you lose all your lower extremity. What steroids should I use, Rachel? Get in the brain real fast. Dexamethasone. Good job. All right, that's, see, otherwise you can go read the article. Oh, dexamethasone should be good. Anyway, the way, again, figure things out. That way, when you read it, I go, oh, I know why they chose that one. Why did they choose all the other ones? Because that one enters the brain faster than anybody else. So anyways, dexamethasone first, and then taking the surgery. See, the dexamethasone buys you time. Otherwise, you have to do emergency surgery. But with dexamethasone, you can take them later in the day or even the next day and then take care of the surgery part. All right, that's called Equina. Any questions on that? Then Conus-Medullary syndrome. Sandra, Conus-Medullary involves which nerve roots? 4 and 5, only 4 and 5. So S4 and S5, where do I find that? Sandra, where do I find S4 and S5 on your body? The anus, 2 circles around the anus. All right, so this is called, perianal anesthesia. The person will tell you, when I wipe, doc, I can't feel a thing. That's how they'll present to you. Because one day they're wiping their butt and they all of a sudden, why come I don't feel anything? That's because that nerve is being compressed. All right, so cauda equina is the final cone, and it's S4 and S5. Perianal anesthesia is a classic finding. Same thing. Dexamethasone right away, surgery to follow. Because you don't want to lose the nerves. Otherwise, they'll be incontinent for the rest of their lives. Who's saying this one? Angie. S4 and S5 is the most, because S3 is a big circle around your butt. It's not close enough to the anus. Yeah, so 4 and 5 are the 2 that I see in most literature. Yeah, so I would just take that 3 out. Just say 4 and 5. All right, so again, steroids first, decompression second. Now let's look at the vertebral arches. So I formed my spinal cord, Gustavo. Now I need my vertebra to fuse around it. Everybody follow? We got vertebra to start out like this, and then we're gonna go like that. Your vertebra fuse ventral, that's your belly, to dorsal, that's your back. Everybody understand? And it's gonna start at the cervical region, C5. If they want to be specific, C5 is where cervical, the vertebral arches start fusing. And it's gonna be bidirectional from there. Again, the vertebra fuse ventral to dorsal, starting at C5 and proceed bidirectional. That means, Gloria, if that baby is pulled out early, you may have an opening still up here at the top or an opening still down here at the bottom because it hasn't made it all the way through. We understand that? Any questions on that? All right, let's look at those diseases. If there's a problem at the top or the bottom. When it's upper, you have to have encephalo in your word. So anencephaly says it never went to the top at all, and that's why the brain never developed. This is just like ureteric bud and kidney. If they don't make contact, there'll be no brain. Anencephaly, all you see is a medulla and nothing else. Remember that open neural tube defects will have high alpha fetoprotein. Or now they'll talk about acetylcholinesterase. All they do, just any neurological protein is fine with me. I don't care what they want to call it. So anencephaly. Encephalocele, the term seal at the end is a pocket. That means it's not open. But there's a pocket here at the base of the baby's neck, just full of fluid. The encephalo just tells me it's up here, not down at the bottom. So encephalocele, you need to get a neurosurgeon because eventually the child's going to need surgery. It's not an emergency, but he's going to need it. Encephalomenincocele says you have a pocket at the base of your brain, but it's got meninges in there. And you have 3 meninges. Ramondo, what are 3 meninges? All right, Miguel, can you help him? All right, dura, arachnoid, pia, dap coming down, pad going back up. Okay, so that means one of those meninges is stuck in this pocket. That's what they'll describe to you. In babies or in children overall, we do MRI. Why? CT scans cannot see the posterior fossa. This is all posterior fossa problems. Just so you know why we do MRIs on children. Because why waste CT scan money? You still can't see the back of the brain. All right, so that's an encephalomyelin. And then the worst one, encephalomyelin. When you put myelo, that means brain is in there as well. You got a pocket seal at the base of your neck, encephalo, but it's got meninges and brain tissue in there. That's the worst form. Why? Because everything from that point downward is messed up. Because the spinal cord is now stuck there. Well, that means the brain cannot send fibers down to the rest of your body. That's the worst type. Now, encephalomyelin myeloceles are also associated with arnocardial malformation and syringomyelia. So they'll ask you, what else do you need to check that baby for? Encephalomyelin. Can be associated. Now, it's not automatic. It can be. Lower vertebral arch defects. We just don't put encephalo. So spina bifida is a term we use. So spina bifida occulta means it's open down at the bottom, but it's hidden by skin. Occulta means hidden. How do we even know it's there? There's always a big tuft of black hair right over it. And that's what they always say. Every time I see that question, they say, a baby, some newborn comes to see you, or you see him in the newborn nursery, and you see a big patch of black hair in a circle area. That child needs an MRI because they got spina bifida. Again, they're gonna need surgery eventually, but it's not an emergency. As long as it's not open, we're good. Spina bifida aperta, open neurotube. That's gonna need closing right away. So what do you do for that baby? Put sterile towels over it right away. Otherwise, meningitis is gonna happen. Remember, there's germs right in the delivery room. So spina bifida aperta, sterile towels over it, get a neurosurgeon, they need surgery immediately to close that area. Any questions on that? Meningocele means now the meninges are sticking out. And meningomyelocele, you got meninges sticking out and you got brain tissue sticking out. And as you can see, the worst type can always be associated with arnocardial malformation and syringomyelia. Now, what is syringomyelia? A suction in the central cord. They call it central cord syndrome as well. Okay. So, so let's say if you start at the cervical region, cervix, fuse. You now have a tunnel here. That tunnel has negative pressure in it compared to out here, which is a little more positive. And that's why you can get sucked in like that. And that means now the whole central cord is smashed. That's it. Remember, cape-like distribution from that level down, gone. C5 is your shoulder. The cape drapes all the way down to your feet. No good. Unfortunately, there's no treatment for it. Right now, all they do is steroids, dexamethasone, and see if that helps. From what I've seen, I haven't seen anybody get better from it. It just gets worse over time. So syringomyelia. Arnocardial malformation is also a vacuum suction. It means the base is the, let me think about it. Yeah, floor to fourth ventricle sucked down into the spinal cord because of the vacuum. Same vacuum I just discussed. Notice they both connect to that same vacuum. All right, but now you got the floor to fourth ventricle pushed down, and that way it occludes canals of Luschka and Magendie. You guys remember that's where CSF is supposed to drain into the spinal cord. It's closed. They're going to get severe hydrocephalus if you don't put a shunt in prophylactically. That's why we screen for this. Okay, again, MRI, because if they have it, you need a shunt before it starts smashing their brain. All right, because once the brain starts getting smashed, that's permanent damage. You can't get it back. Any questions on these two complications? All right. Now you need some CSF. So we got a spinal cord developed. We got the vertebral arch fused. Now I'm going to put some CSF in here. Any questions where I'm at? I want to make sure nobody's lost now. We're just doing it one piece at a time, bringing everything together. CSF. A CSF is a filter to your plasma. It's made by the choroid plexi in each ventricle. You got two lateral ventricles, each one in the parietal lobes. You got a third ventricle right along the midline, midbrain. You got a fourth ventricle at the base of your medulla. Two lateral ventricles, both in each parietal lobe. a third ventricle at the midbrain, then a fourth ventricle at the level of your medulla or cerebellum. Remember that all fluids in your body require the same enzyme, or carbohydrates. That's never been a false statement. Okay, so also you require vitamin A. You talk about pseudotumor cerebri. Vitamin A is a cofactor for this. Any questions on that? Your CSF. Now the question is the difference. Your CSF difference in plasma these two ways. Less bicarb. Now, how do I make sense of this? So I'm not just memorizing. Because bicarb is a large molecule. It can't cross the blood-brain barrier. So it's easy to remember. So again, go back to something basic that you already remember, you already understood, and it makes it easy. So if you have less bicarb, then somebody else has to make up for negative charges. That's chloride. See that? That way, more chloride makes sense to me. I don't have to memorize that. If you have less bicarb, oh yeah, that's why it's slightly acidic. Again, makes sense to me. Versus I'm just trying to memorize 3 things I read out of a book. Okay? Make sense of information as much as you can. You can remember that for many years without having to guess. Okay? Early on, folks, your blood-brain barrier is wide open. It closes between 1 and 2 months. Blood-brain barrier wide open. Closes by the end of 2 months. For that reason, any child who has sepsis before 2 months of age is about to get meningitis. Everybody understand my statement? Because everything's continuous. Any bug has free access to his brain. Everybody understand that? Neonatal sepsis. So the first 2 months, the bugs that attack the baby. Gloria, you remember the 3 bugs? Yeah, first month of life, outside of the uterus, correct, outside the mom. Yeah, so I use Baby Bell to remind me. B is for group B strep, E. coli, and Listeria. And the best antibiotics for a newborn, you remember that combo? That's all right. You remember? Ampicillin and gentamicin. This is what I was trained on back in the 80s, and it's still the most effective combo till today. By my last review, so only a few months ago, still the best combination. And I still see them test questions, still the answer. All right, but anyway, just so you know, the way I in our residency, I remember our chairman said, hey, any baby under 2 months who looks sick, automatic hospitalization, automatic full septic workup, including lumbar puncture, automatically gets put on these antibiotics. Because he's not gonna gamble with anybody's baby. Because if you gamble and you're wrong, baby's dead. Or the baby has severe brain damage. You don't want that kind of lawsuit. Those are big ones. All right? So that's why for the first 2 months, because the blood-brain barrier is wide open. Everybody understands. It's got to make sense to you for you to remember it. It's wide open. That means any bacteria in the blood enters the CSF with no problem. Okay? All right. Up until the first month of life, you can have up to 25 white cells. That's because the lymphatics have continuous circulation through your brain. But once the blood-brain barrier closes, it should be 0. That's why they say if you even have 3 or more, that's just for human error, 3 or more, you got meningitis. Then you got to figure out why the person has meningitis. Any questions, first of all? All right. Xanthochromia, when you do a lumbar puncture. All right, where do we do a lumbar puncture? Anam, you out there? I don't hear. Leslie, where do you do a lumbar puncture? Which nerve, which space should I go for?
Sorry, I was having trouble with my mic.
Oh, there he is. Okay. Yeah, I want to make sure you knew this. Where do I do a lumbar puncture? Which gap?
L3, L4?
Yeah, L3, L4. Remember, it starts at L1, L2, the iliac crest. We feel for the iliac crest, and then we just go 2 dermatomes down. Why? That way that needle is nowhere near the spinal cord. Right, follow? Again, it's got to make sense to you. You want to go beneath the spinal cord. That way, in case you go in a little too far, you're not stabbing your spinal cord. Okay? All right. So xanthochromia is when CSF has mixed with blood. Xanthochromia is a term we use when CSF has mixed with blood. So in that way, if you get blood in your CSF, I got to know, did I cause that with my needle? Or is there really blood in here? Xanthochromia says there's really blood in here. See, if it's negative, see over here on the right, bloody tap? So I'm seeing that question on UWorld, just to see if you knew that. Okay, xanthochromia tells me, yep, they did mix. It's a nice pink color. Whereas bloody tap, the blood is on top of the CSF, but they haven't mixed. All right, positive xanthochromia says blood is really in there. So first thing to evaluate for, subarachnoid hemorrhage. That would be an adult who had subarachnoid hemorrhage. Worst headache of your life, right? Thunderclap, wham, they hear a big clap, blam, they go straight to the ground. Why? Because their legs just got taken off from underneath it. Thunderclap headache, they hear a sudden bang and their legs go out from underneath them and they fall straight down. And then that blood starts leaking into the subarachnoid area, and that's why it starts going down the back of your neck. And now you got neck pain like you got meningitis. So we do a lumbar puncture and you see a whole lot of blood. Okay? Subarachnoid hemorrhage. The problem with that blood leaking out is if that blood touches a blood vessel, that vessel goes into spasm. So now not only do you have a bleed, you have an ischemic stroke right afterwards. And a lot of them will die. So that's why we started giving them a calcium channel blocker, Gloria, to block that second vasospasm. So what calcium channel blocker do we give after subarachnoid hemorrhage? Calcium channel blocker after subarachnoid hemorrhage. Leslie Gonzalez, remembers?
Yes, nimodipine.
Yeah, remember, nimodipine is now.
I
given.
have a question, doctor. Like,
ahead.
we try to diagnose, like, do the diagnosis of subarachnoid hemorrhage first with CT scan, but if we cannot see the bleeding, we go
Correct.
to lumbar puncture, right?
Then you go to lumbar puncture, correct? Yeah, so CT scan first, lumbar puncture second. All right, what else can we evaluate for with xanthochromia? Number two, herpes encephalitis causes a lot of bleeding. But that bleeding is usually in the temporal lobe. So when we do it as infectious disease, that's the clue I'll be giving you. But in case they give it to you this way, all right, xanthochromia, well, you have to worry about herpes encephalitis. But again, CT scan will show you the temporal lobe is just lighting up with inflammation. Third one, intraventricular hemorrhage is the most common cerebral hemorrhage in premature newborns. So if the baby was premature, then I know that's what they're going for. Why is that? They have very fragile vessels right along the midline. All right, that's the medial wall of both lateral ventricles. They call that the germinal matrix. Because they almost always ask for the anatomy. You know, where's the bleeding coming from? If it's a premature baby, always pick that. Germinal matrix has the most fragile vessels in the brain. And with prematurity, what do? We got to promote oxygen, free radical damage. The free radicals will pierce through these vessels before anybody else, before any other vessels. And that's how you get this. Well, when you bleed right along the midline, which fibers are right along the midline, Solange? Arms or legs? Legs, so you lose your legs. What was the name of that cerebral palsy? OE. Spastic diplegia. Remember I told you it's the most common type of cerebral palsy for that reason, because we saved so many premature babies now. So many of them end up with germinal matrix bleeding, and that's it. The leg fibers scar up, and they're lost for good. Spastic diplegia. All right. So if you want to prevent free radical damage in the brain, Solange, what vitamin do you want to give these babies? Yeah, it's vitamin E. It's now given routinely to all premature babies. See, so when that article comes out, I said, oh, I already know what they're doing. That saves you from having to read the whole article. Because you know the attending is going to drill you. I mean, if you're a pediatric family practice, you know the attending is going to drill you. And say, well, what are we supposed to do for this? And if you haven't read the article, now you're in trouble because you're supposed to keep up with this stuff. But if you already know the whole thing, you say, oh yeah, I know why we're doing that. And now you can explain it to him. He'll swear you read the article, but you did. But you know the article, that's the point. Okay. All right, Anam, you have a question?
Yes, sir. So, onset of herpes encephalitis is, I mean, not the onset. Isn't it deadly by the time it touches 48 hours?
Wait a minute, say that again? Outside of herpes?
Herpes encephalitis is rapidly active, right? So like the person's gonna be like really toxic by the time it's like 48 to 78 hours.
Yeah, oh yeah, herpes.
So
kills
then, I
me.
mean, what will be the what will be the benefit of doing an LP, because blood does not show up until 48 hours, right?
No. Blood shows up right away.
Blood shows
Remember,
up.
like, if you have a stroke, hemorrhagic stroke shows up right away. It's ischemic stroke doesn't show up for 48 hours.
Got it, okay.
Yeah, I think you flipped it, yeah.
Thank
All
you.
right, Mabel, you have a question?
Yes, sir, please, I will give him vitamin E because it's an antioxidant.
Yeah. That means they'll eat up the free radicals so they don't damage your germinal matrix and cause bleeding.
Okay. Thank
Yeah,
you.
they've already shown that it decreases the retinopathy of prematurity, which is caused by the same thing. Okay. All right, so blood in the CSF, xanthochromia. Remember, subretinal hemorrhage number 1, herpes encephalitis, and then intraventricular hemorrhage if it's a premature baby. Now, subretinal hemorrhage almost always comes from a baryaneurysm. Baryaneurysms in the general population is found along the anterior cerebral artery circulation, which is why they lose their legs. You guys remember ACA, right along the midline, the legs are gone. But if somebody has polycystic kidney disease, where do you find the baryaneurysms, Jess? Where posterior what? Posterior communicating, not posterior cerebral. Posterior communicating artery, which is right above cranium of 3. So it crushes cranium of 3. They're coming with a blown pupil because 3 has been compressed. Huh? No, pica's different. Pica's lateral medullary. So subarachnoid hemorrhage, baryaneurysm, general population, anterior cerebral artery. That's why their legs go out. But in polycystic kidney disease, obviously they'll tell you about the dad who had it or the mom. You may saw someone down it. Somebody else got it. All right. Or they'll talk about the kidneys are big on exam. They'll hint at it. But then they'll ask you, where's the baryaneurysm going to be found? It's not the general population anymore. You have to say posterior communicating artery. Okay. All right. Any questions on xanthochromia and what it means? Cool.
I have-
Subarachnoid hemorrhage.
I have a question that
Okay. All right, go ahead.
in renal physiology, like Dr. Shaw said
Uh-huh.
that in the past, the anterior communicating artery was the most common on the population,
Right.
but and the posterior in polycystic kidney disease. But he said that now also on the general population is the posterior. I don't know if
No, it's starting to swing to the posterior, but it's not the most common yet.
okay, so it's
Yeah,
still
on the test, they're always, yeah,
posterior.
still, right, that's what I'm teaching you, what information gets to the point when you get the exam. Yeah, you gotta pick what is the most common, that's what they want.
So the most common will be the anterior.
Anterior, right, for the general population, posterior communicating for, polycystic kidney disease. I just did a question about a month ago, and that was still the answer.
Okay,
Again, I
thank
don't
you,
switch
sir.
until they switch. All right, so subarachnoid hemorrhage, any questions on that? Let me just go through it all again for you. A sudden clamp followed by the worst headache of your life, can't miss it. Blood is very adhesogenic, I made that point yesterday. Baryaneurysm is the most common cause, hypertension is the most common cause of the bursting. Remember, just like dissection of the aorta, hypertension will cause it. Otherwise, the aneurysm is just sitting there doing nothing. All right, after the bleed, there's usually another ischemic event caused by arterial vasospasm, and that's why nomodipine made its name in the market, the best drug for that. So anybody with subarachnoid hemorrhage, we always start nomodipine ahead of time. You don't wait till they get a stroke. All right. All right. So again, anterior cerebral artery in the general population and polycystic kidney disease in the posterior communicating, that's why cranial 3 gets compressed. Meningismus, the next term. Meningismus is a term for your neck is stiff. That means your meninges are being pulled on. Meningismus, your neck is stiff because your meninges are being pulled on. How do you know that? Called Koenig's and Brzezinski sign. Koenig, K for kick. So when you do straight leg raising, oh, they pull their head down like that because you're pulling on their neck. They don't like that. So that's a positive Koenig. Brzezinski, B for bend your neck. So if I try to bend their neck like this, they mean to pull their hips up. Again, to take the tension off their neck. So Koenig and Brzezinski sign, easy to do on exam. Okay, they're specific, but not sensitive. Meaning most kids don't have it, but they still got meningitis. But if you have this, okay, then you got meningitis for sure. But I don't know if it's bacterial. Otherwise, you just know there's meningitis. Any questions on that? So that's why you got to do a rule out meningitis workup. Okay, meningismus. So I just thought my fantastic artistic skills. Just so you have a visual on what I was talking about earlier, two lateral ventricles in the parietal lobes. They go through the foramen of Monroe. Oh, you laughing at my picture now? So there's a foramen of Monroe coming from the right and one from the left, and they drain into the third ventricle, which is in the midbrain. And then you go through the aqueduct of Sylvius, get into the fourth ventricle, which is down at the medulla. And then you go through lateral Luschka and then medial, the canals of Luschka Magendi to get into the spinal canal. Any questions on that? Yes.
I guess I didn't realize, I don't very
A berry aneurysm leads to the subarachnoid hemorrhage. That's correct. Yeah. Yeah, one leads to the other. Yes, I'm sorry. Oh, so now they found a fourth membrane? What's the fourth membrane called? Subarachnoid light. Oh, so they haven't given it a name yet. I haven't even seen that in the literature. I didn't know that. When did they find that? There's a fourth membrane now? Ah, yeah, okay. Oh, not everybody has it. Maybe that's why I haven't seen it in any test questions. I haven't seen it in the literature either. Yeah. Yeah, so, okay, anytime you guys know of some new discovery, please share with me, because nobody knows everything. I don't know, always know everything either. They found a 13th cranial nerve now? Wow, woo, look at that. I didn't know that. I haven't heard that from anywhere. Anyway, it's not on your exam now. That's why I'm always afraid to talk about it. Somebody start picking that stuff on the exam, like you're gonna get a point for it. I don't think so. All right, you won't get a point for it. All right, Abdullah Khan, you have a question?
No, I just wanted to tell you that they're making a vaccine for what's it called? What do you call it? The opiate. What's the biggest opiate killer right now? I'm forgetting the name.
A what? A vaccine for fentanyl?
Yeah. Yeah, they're making a vaccine for
How
fentanyl.
do you get a vaccine against a drug?
I think they're making like antibodies for it or something. They're
Oh, an antibody against a drug. Okay, I can see it.
that's what they're
Remember now
called.
that we can make a map against anything. Remember, we can make an antibody to go find a gene for you. That means you go all the way to the nucleus and get it. So you can make an antibody go against anything you want. All right?
They're working on it. in-
Myeloma cancer to do that. But I didn't know they had one against fentanyl. That would be great if they could do that. You know how many people die every day from fentanyl overdose? A lot. Huh? What good is that? Just blocking euphoric effect.
It's so like.
Oh, okay, so they're making a vaccine to block the euphoric effect. But the only way that's gonna work, that means I gotta give that vaccine to every teenager.
It's like all.
And
No, this.
I don't know if
this
that's
one
gonna
is-
go over too well.
This one is for overdose because like what happens is
It's only
that
for overdose that it can't be, that it stops the high. That doesn't work. It's gotta be an antibody against the drug. If you're talking about treating overdose, if you're talking about vaccinating people, then that means you have to vaccinate every teenager. And then if they ever use fentanyl, see, I see a lot of parents gonna fight that one. They say, well, my kid will never be on drugs. Every parent says that. Yeah, but no kid plans to be on drugs. They just try it one day and before you know it, they're hooked. Yeah, so anyway, it's on the horizon, but it's not on your test, please. All right, so Mabel, you have a question?
Yes, sir, please, I want to know, Magendia and Luschka, did they connect the fourth ventricle to what?
The fourth ventricle to your spinal canal.
Okay, two of them, okay.
Yeah, that way CSF is supposed to drain into your spinal canal. After the draining spinal canal, they go all the way down and then they go into the venous sinuses and get sucked back into the circulation, okay? All right, so CSF flow, and that's why I wrote it all out for you. Again, I wanted to visualize it and then, because on the test, obviously, they'll write it out. But by visualizing this, the other reason is when somebody has hydrocephalus, okay, you look at which ventricles are enlarged. So if only the two lateral ventricles are enlarged, then where's the problem? If the problem's in the third would have been enlarged too. Angie? is the Freeman Monroe. That's what I'm saying. If you can visualize, because they do an MRI to tell you, oh, the two laterals are enlarged. Well, that means the problem's right here. They'll say the two laterals and the third are like, okay, well, the problem's right here then. Everybody follow? All you gotta do is just pay attention. It's an anatomy question, but I see a lot of students miss it. That's how I know students have not studied this picture. Again, that's why I came with the advice. Please look at it, 4 hours a week before your exam. So you remember these pictures, okay? Because they're worth points, okay? A lot of points. All right, so anyway, there's CSF flow. This part again is memorization, but you should be able to visualize it just flowing all the way down and then back into the plasma for full circle. And then here's another, this is a lateral view of the whole thing again. Okay. Now, vomiting centers, you've heard this at least twice. Now you come out here the third time. So none of this should be strange to anybody. The vomiting center, ischemic tachycardia zone is on the floor of the fourth ventricle. All right, responds to any increase in ICP, and it uses dopamine as a neurotransmitter. Aeropostrema, located on the blood side of the blood-brain barrier, responds to offensive smells or particles, uses dopamine as well. That's why Mabel knows dopamine blocker used as antiemetic in children. Mabel knows. This is where you say something, Mabel.
What do you say, sir?
Oh, Lord, I'm telling you this.
Okay,
I'm
yeah,
finna
okay,
look it
sir,
up.
please, wait, sir.
No,
It is
listen
called,
to the-
it is prochloroperazine.
Okay, close enough. That's for the adults. I know she's having a hard time hearing what I'm saying. So anyway, perchlorperazine is for adults, promethazine is for children, metoclopramide is for anybody. All right, so again, we're gonna be rehearsing as we go, folks. All right, otherwise all this repetition is not just so you can write it down again. I don't care about that. You got to rehearse it, say it. Say it if you want to remember it. Writing it down again does not help. All right, but we all have that habit of just writing stuff down over and over again. All right, that's the two vomiting centers. What's the neurotransmitter that governs GI vomiting, Maria? GI vomiting is controlled by what neurotransmitter? Leslie wants to help you.
Serotonin?
Serotonin. And what's the drug we use to treat GI vomiting, Leslie?
Loperamide?
No, not loperamide, that's for opiates.
I don't remember that.
All right, Zaboo, do you remember? Ondansetron, and then he has two brothers now, granisetron or lesetron. You understand, Leslie?
Yes, I remember now, after
All
I
right, no problem.
see it.
Okay, Lawrence? Chemotherapy induced vomiting is GI, because the drugs wear away your GI lining. That's why we use ondansetron for that. Yeah. All right, so vomiting centers, know them and know the drugs. 3 ways to vomit, which we just reviewed. ICP, use dopamine. But the smells use dopamine, and GI distension or irritation uses serotonin. And you just heard all the drugs that we use. All right, hydrocephalus now. You can organize it into communicating and non-communicating. Non-communicating says it's just overproduction of CSF. Sorry, the other way. Non-communicating says you have an obstruction, and communicating says you have overproduction of CSF. All right, the problem is, it doesn't matter how you got it, it applies pressure on your brain, and that's going to be permanent brain damage if I don't do something to help you. You understand, Lawrence? You understand, Reed? Let's do it. Communicating hydrocephalus, that means you have overproduction. In newborns, mainly in premature newborns, that intraventricular hemorrhage I talked about. You spilled blood in there, and then inflammation went in there. That means more fluid entered that space. And now you can have hydrocephalus. Unfortunately, there's nothing you can do about it. Prevention is all we do. That's give vitamin E to all premature babies. Complication takes out your legs. Remember, journal matrix, where the bleeding occurs. The leg fibers are gone permanently, and it causes spastic diplegia, cerebral palsy. In children, due to inflammation from meningitis. Most common cause of meningitis in children, strep pneumonia. In adults, it's overingestion of vitamin A. But remember, vitamin A toxicity right now, most common cause is obesity, not taking pills by mouth. Obesity is number one. That's how we talk about pseudotumor cerebri. Leslie, do you have a question?
Yes, I always have these questions. I'm sorry, that's Siri, like, no. My question is, why, when you have communicating hydrocephalus, Mostly patients herniate, but with cellular tumor cerebri, there's not risk of herniation.
All right, so wait a minute. Oh, so when people have hydrocephalus, there's a chance of herniation, is that what you're saying?
Yes, but
Or
when,
pseudotumor cerebri, there's no chance of herniation? Well,
Yeah.
pseudotumor cerebri, there's no chance of herniation because you got overproduction of CSF and the CSF is within the brain. There's nothing actually pushing on the brain at all. Right, follow that? The other hydrocephalus that can cause herniation is because of an obstruction by a mass. It's the mass that causes you to herniate, not the CSF. You understand, Leslie?
Yeah, I
It's the
got it.
mass that leads to herniation, not the CSF. Because CSF is in the middle of your brain. It's not pushing on your brain. All right, so adults, pseudotumor cerebri. I remember you see enlarged ventricles, vitamin A intoxication, obesity is number one cause. What do we do if she's overweight? Most of them are she, that's why I say that, because we put on, remember, acetazolamide until we get her to lose weight. Okay, otherwise she'll be back with the same problem again. Yes. Strep pneumonia, yes, is the most common cause of meningitis in children. And only after 2 months, correct. That's what I'm actually doing that just off the top of my head. Because I just say, let me just create some repetition. We do it all in micro, but I said, let me just throw it in as we go. All right, so you write it down if you want, but it's all in your notes later on. But again, I'm just trying to help you so you hear things several times. All right, anyway, that's adults. Elderly due to brain atrophy is called non-repressive hydrocephalus. That's because as your brain atrophies, the ventricles get sucked into the vacuum and they enlarge. And because they compress the midline fibers, what happens? Their legs are gone, wobbly. The bladder fibers right there, incontinence. Remember, wet, wacky, wobbly. Notice how it all connects to one process. That's why I always like to go back to the beginning. How did we get this? Instead, I got to memorize, 3 things I'm supposed to know. That's what we were all taught in the beginning. Just memorize these 3 things. That means NPH. Okay? What do? Put in a shunt. Put in a shunt. When you put in a shunt, one of these 3 things will not clear up. Jess, which one will not clear up after the shunt? You got dementia, incontinence, and ataxia. One of them will not clear up. Dementia, you can't bring back brain tissue, folks. But it's a great test question because unless you understood that, you would never get it right. Yeah, but the incontinence and ataxia go away because you're not compressing the midline fibers anymore. Now they can walk straight and they're not peeing all over themselves. Steve, you have a question?
Good morning, sir. I'm missing the connection between like why when you have this increased pressure, why is it taking out the midline fibers?
That's
I'm
because
missing the anatomical connection.
Yeah, the anatomical connections are 2 lateral ventricles. You go back here. Right here. These 2 lateral ventricles, the edges here compress the midline fibers. The midline fibers run right through the middle like that.
The
So
midline
these 2 enlarge, they crush the fibers running right between them.
midline fibers of the what?
Of the brain.
Okay.
Remember, the midline fibers of the brain are for your legs and the bladder. That's why you lose both of those.
Thank you, sir.
Yeah, the homunculus. All right. All right, so that's your differential for communicating. Any questions at all? That's communicating. Oh, somebody else went. Idonis, you have a question? Idonis? Okay, thought I had a question. All right. Non-repressive hydrocephalus again, put in a shunt. All right, this shunt. The problem is that shunt has to tunnel underneath your skin, from the scalp, behind your ear, to your neck, mediastinum, all the way down to the peritoneal cavity, which is what I call a ventricular peritoneal shunt. The problem is you're running through the epidermis for quite some time. That's why staph epi becomes your worst enemy. So anybody who has a shunt, the minute they get a fever and any neurological problems, immediate hospitalization, take the shunt out. Culture the tip, that's where staph epi likes to hang out. It forms what they call a biofilm. It's like a little clear gel. And it hides underneath it. So your antibiotic can't touch them and your immune system can't touch them. That's why they say take the shunt out immediately. And then after you clean up the infection, put another shunt back in. Otherwise, the patient will die from it. So anybody with a shunt, if they ask you what bug you have to worry about, always know they want staph epi. If they get a fever, any neurological problem, immediate hospitalization. Don't say, oh, it's just a cold. We don't know if it's a cold, but you're going to hospital because this will kill you if I'm wrong. Okay? All right. Non-communicating hydrocephalus due to some form of obstruction. Again, that's why you gotta know the differential. In newborns, number one, aqueductal stenosis, that's aqueductal sylvius. If it's aqueductal sylvius, Gustavo, which ventricle will be normal sized? The fourth. So you'd rather ask you which one is in large, they can ask, oh, which one's gonna be normal size? Because that's how they describe it when they say MRI shows, and then say third and the two laterals are enlarged, but fourth is normal. So that's aqueductal sylvius head. Okay, that's because the picture's in my head. That's why I say make sure you look at these pictures right before your exam. All right, that's aqueductal sylvius. Obviously, to go to surgery and try to open that up. Danny Walker cyst is a cyst on the floor of the fourth ventricle that includes Lusca and Magendie. So now all four ventricles will be enlarged because everything's just backing up. And then again, we go into surgery. We come in from the back here and just open up a little bit of a flap and go right in and cut the cyst out. Okay. In children, meningitis, usually tuberculosis. What kind of necrosis do you get with tuberculosis? Abdullah Khan.
What was the question again?
What kind of necrosis do you get with tuberculosis?
Caseating?
Caseating, that cheesy junk clogs up Lusca and Magendie a lot. And that's why you get a high incidence of hydrocephalus with TB. In adults and elderly, cancer. And what's the most common brain cancer for adults and elderly? Steve?
For, I know the most common is meningitis.
That's not what I asked though. I said, what's the most common cancer? Meningitis is not a cancer. Make sure you stay
Metastasis.
in a category, yeah. I figured he tried to say metastasis, but meningitis came out. All right, yeah, metastasis is number one, very good. All right, so now communicate, any questions on, again, we're just going step by step here. The role of CSF to do what? Add cushion for your brain. I just like amniotic fluid around the baby, add cushion. That way, if I hit you, the CSF absorbs the shock, your brain doesn't get hit. All right, so shock absorption is the number one job. So head injury, coup and contra coup, how does this happen? All right, so let's say if you hit the left side of my right side of my head, all right, I got CSF right there to cushion a little bit, right? And then you push my brain to the left. All right, everybody follow? If the brain is right next to the bone, then wherever I hit you, that's where it's gonna hurt. That's called coup. Coup is a direct impact. That's called a contusion. Blunt force trauma on solid tissue equals contusion. So a brain contusion. Now, on the two sides, folks, the brain is impacted. If you guys remember the way the skull is, these ridges on the sides and in the front and back. So when you get hit on the side, the brain does not move. Wherever you get hit, that's where you're gonna suffer trauma. Everybody understand me so far? Is when you get hit in front and back, there's some space, and that means the brain can move back and forth like that. Right, follow me so far? Then you really got to worry about contra coup. So let's say you hit me in the front of my head. If my head is moving, then that means the CSF in the front will immediately splash back here like this. Everybody know what I'm talking about? You hit the fluid, moves quickly over back here. That means the back is cushioned for a second. Everybody follow? And then as you rock back, that CSF comes flying back to the front. And that means the brain now hits nothing but bone because CSF flew to the front. Contra coup is worse. So when you get hit, if your head is moving, contra coup is worse. If your head is fixed, coup is worse. Everybody understand that? First of all, anybody not understand it? Well, then, yes. Which part? Contra coup is if your head is moving, that means your brain can be pushed to the back. So at first, CSF goes to the back, it's cushioned. But as your head rocks back, CSF flies to the front. That means brain comes and hits nothing but solid bone. So the contra coup is worse than the coup. Yeah. Everybody understand that? Then therefore understand that. This is why when you're boxing, okay, or fighting, when somebody gets, one fighter gets the other person on the ground, why do you think the referee pulls them apart? Because that means every punch is a coup, because the head is fixed. It's sitting there on the canvas. It has permanent brain damage every time. Bam, bam, bam. That's why these fighters, They don't look so good after a while. What? If your head is fixed, your head, what? What other one? The contra coup? The contra coup is worse if your head is moving. That means if your head is able to move. Inertia is if your head is just sitting still on the ground. We're about to punch it. I'm doing damage to that site only. But if your head is moving, like in a fight, you know, you're doing all that. That means your brain can shift. That means if I hit it in the front, the brain will slide to the back and hit bone. That's even worse. Yeah, because there's no CSF. Remember I told you, as your head rocks back, CSF splashes to the front. And that means brain tissue hits bone tissue. That's not good. Okay? So coup lesions, when your head is fixed, that's why in the middle of a fight, wait a minute, Mabel. That means in the middle of a fight, like boxing, once one guy gets the other guy down, the referee breaks him apart. Because that guy on the ground is about to suffer some bad brain damage. Everybody follow? With contra coup is when people are fighting standing up. So when you get hit, the opposite side of your brain took the most trauma. Well, folks, if I keep traumatizing your brain, eventually you're going to suffer permanent brain damage. Have you ever wondered why people coin the term dumb jock? A dumb jock, a dumb athlete? That's brain damage. But back then, nobody knew what it was. You guys have heard the term before. Anybody? Nobody's. Some of you guys have never heard the term dumb jock before? Oh my God. Jeez, okay. Anyway, it's a term that they use all the time, dumb jock. Why? This is what used to happen on TV back in the day, before they understood this. All right, we're here to interview our champ, leading quarterback for the team, and he's gonna tell you what's gonna happen in the game. Hey, champ, what's gonna happen in the game? We're gonna play our team. I think I thought put it down. I know I did, yeah. You're like, what the hell's wrong with this guy? And everybody used to say he's a dumb jock. He wasn't dumb when he joined that team, but because he's been hit so many times, he's got permanent brain damage. The guy could barely speak English now. And so everybody used to think, oh, athletes were all stupid. They're not stupid. It's the complication of the sport. Okay? That's before we understood. That's where it was coming from. Okay, now that we know it's coming from, why do you think they put helmets on? Now you see less of it. Why do you think they have concussion protocols? See? Took a while to understand that. So boxers, think about boxers, man. After years of boxing, talk to them. They don't sound so good. That's permanent brain damage. Remember Muhammad Ali, who barely ever got hit. What did he end up with? Parkinson's. Almost every boxer ends up with some brain damage, whether you knew it or not. All of them do. That's because of all this. Coup and contra coup happened for years of boxing. All right, they paid a price for all that money they're making. They pay a huge price. Okay, and then think about in football. All right, what do they call it? CTE. Yeah. How come they're demented in their 40s? That's brain damage. Over the years of being hit over and over again in football. And after a while, your brain is just not working anymore. Athletes commit suicide at a very high rate. Why? Because they see themselves slipping in their 40s. And they said, no, I can't take this. They commit suicide. Right? Because all of a sudden they don't recognize their wife anymore. They don't recognize their kids anymore. It's a bad deal. But, you know, when that movie, I can't remember that movie, Will Smith, what's it? Concussion, yeah. Years ago, I was aware of this one. Years ago, when they found out some of this stuff, right? They asked the athletes, knowing now what we know, would you still play sports? Over 90% say, hell yeah, I'd play sports. They could care less what the brain damage was. Why? Because the money. The money. Because remember when that concussion came out, all of a sudden the athletes said, oh, we're going to sue the NFL. I said, you guys ain't going to win. Because I knew of a study where they were warned. Here's the info. Would you still do this again? Okay, go back to playing then. You're an adult and you made a decision. You don't care about brain damage in your 40s? Play sports. I mean, the owners were happy. Great, go play. But you're not going to sue them 20 years later when they warned you 20 years ago. It was your choice to keep playing. So I already knew. That's why you don't even hear about the lawsuit, because it got dropped. Because it ain't worth nothing. You were warned. That means it's your decision now. You can't blame it on anybody else. Okay, but that's why there's a concussion protocol, at least so it's not so severe. Okay, but that's normal. All right, so, okay, let me get these two hands here. Latoria, you have a question?
Yes, I was wondering if you would see counter lesions with car accidents.
Oh, heck
Often.
yeah. Yeah, that's like whiplash. You know, your head's going one way and all of a sudden it snaps back the opposite direction. So now the opposite part of your brain got hit harder than the first one that got hit. Yeah, counter is real common in car crashes. Aaron Hernandez's brain? No. Oh, the one- he murdered people. Yeah, okay, I heard that on the news. Oh, I never seen.
And then they did an autopsy and they found he had extreme cases. And it's like getting a large ventricle that was bad.
Yeah. I'm telling
He
you.
was like 27.
Yeah, 27-year-old with all kinds of brain damage from playing football. Folks, again, like I said, they were warned over 20, well, now probably about 30-something years ago. And they said, no, we like the money. We want to play. They said, okay, keep going. But that's why at least they've experimented with helmets, trying to make it safer and safer. But no matter how safe you make it, you're still getting hit every play. You're suffering brain damage, whether you like it or not.
They say sending your kids to play college high school football is like having a car crash.
Yeah. Yeah, sending your kid to play football is like getting into a mini crash every day. That's why now a lot of parents are rethinking letting their kids play football. Because all this evidence that is coming out is that, man, even though it's good money, you don't know if it's worth it anymore. But anyway, each person has to make their own decision. Mabel, you have a question?
Lisa, I want to find out if it said that concussion is the one that is the bad one, right?
No, coup and contra coup. The key is, it depends on how it happens. A contusion is just blunt force trauma. Then it can cause a coup or contra coup.
Okay.
Okay. So blunt force trauma to the brain or any organ, like when you hit the steering wheel with your chest, that's contusion of your lung, contusion of your heart. So blunt force trauma against any solid organ equals contusion. I'm just going through definitions so you guys understand it. All right, Leslie, you have a question?
No, I was, we were talking about like athletes. So I don't know if you remember the famous Puerto Rican boxer, Prisher Colon. Like he was boxing on 2015 and with a hit on his left side of the head, he got in a coma for like 5 years because of subarachnoid hemorrhage.
Yeah, that's what contusions can do. Because depending on what's nearby, that force is going to hit. Something has to absorb the force, and it's your brain. So depends on what part of the brain got hit. So that's why you got to know what a coup versus contra coup is. So if I get hit with my head standing still, then the front is where I'm going to have damage. If my head is moving, then it's the back that I'm going to have damage. Either way, a part of your brain is going to be damaged. Okay? All right. Contusion. Now you know what it is. What about concussion? Concussion says neurological deficits right after the contusion. So that's why it can be as mild as a little groggy. And then within a few seconds, I'm all right, coach. I'm all right, coach. So in the old days, they didn't understand concussion very well. So they came out with a concussion, when they first started coming up with a concussion protocol. They came up with a protocol that was so difficult, most people couldn't do it. They would ask questions like, who was the third president of the United States? Hell, most people couldn't tell you that. But they didn't know that back then. They made it difficult. You know, so they started asking about math equations. Oh, hell, 40% of people can't do math. So they would ask them those questions. And before you know it, the quarterback was eliminated because you got to sit down. They asked the same questions. The very next hit to the backup quarterback. Hell, he's eliminated too. He doesn't know the answer. Before you knew, the whole damn team was eliminated. They said, what the heck? How are we going to play a game? That's because they were using crazy questions. So somebody did a study and said, okay, let's just ask the questions when there's no game going on. Let's just ask all the players. And 90% of the team failed the test. They said, oh my God, that's the problem. The questions are too difficult. So now in the NFL, they ask you simple questions. They ask you what your name is. What day is this? What sport are we playing? What down is this? That's questions almost every athlete knows. Now that's the protocol, okay? Because if you don't know that, then you got hit up pretty hard. Then you got to take it out. All right, and if you got hit pretty hard, Gustavo, What's the first sign that your brain has been damaged? Swelling. What cells show up first? Neutrophils, when they first show up? 4.5 hours, predominantly by 24 and peak of what day? Day 3. What cells show up at day 4? Macrophages along with? Yeah, they always travel together now. No, I always say one without the other. So T cells and macrophages show up at day 4, peak of what day? 7. Who shows up at day 7? Fibroblasts. So does everybody see fibroblasts don't show up for 7 days, right? That's why in NFL, there's a 7-day protocol. You cannot play for 7 days. That means at least some fibrosis has started. That means your brain is intact. That's why they say, well, it's day to day. We'll wait till next Sunday and decide. Next Sunday, a neurologist takes a look at you and asks you some questions. If you answer everything, okay, your brain's fine. You can play. But if you miss any questions, you're not ready yet. Because even worse than this, folks, is something called second impact syndrome. Anybody see Ty, what's his name? The Toa, what's his name? Oh my God, remember got hit on a Thursday? They got hit again on Sunday? God damn, they died on the field. Second impact syndrome says for 7 days, you got an area of the brain that's mushy because it's edema. If you get hit again, that area goes, it's not solid tissue anymore, it's wet tissue. It splatters. That's it. Permanent brain damage done. That's why they died right there on the field. He was lucky, but notice now they had to pull him out because he had a lot more damage than they thought. That's second impact syndrome. Second impact is worse. And that's what used to happen in sports before we understood this. An athlete would get hit once, and after they get the groggy out of it, he go back in. Get hit again, dead on the field. Dead on the field. Nobody knew how it happened. So somebody started doing all these studies and saw second impact is the worst. So that's why they say, no, once you get taken out, you cannot play for these 7 days because we don't want that area to be mushy. If you get hit, that's splatter. That's it. That's brain tissue gone. Embryology of the brain. Any questions so far? We've done all the spinal cord now. It ain't the brain. This is the part you got to memorize because they will ask you, forebrain gives rise to what? Diencephalon gives rise to what? This part is just memorization, obviously. But it's worth doing it. That's what I'm just pointing it out to you. Okay, as a pediatrician, obviously, I got to know this because parents are always asking you, oh, if my child is missing that, what's that mean? That means you got to know what can he not develop? And then give the mother an idea of what he's not going to be able to do as an adult because he's missing this. Okay? Any questions? I'm just going to go in order. Go through the brain. Here we go. How to organize neurophysiology. Start with the cortex and then come all the way down. Everybody understand? I did the spinal cord, coming up to the brain. I'm going to go to the top of the brain, come on down. Visual cortex. The best way to organize visual cortex, Ashley, is know that everything is reversed. They say right, I pick left. They say up, I say down. They say inferior, I say superior. You understand, Ashley? Let's see if you do. Somebody's got a right inferior quadranopsia. Where's the lesion? Right inferior quadranopsia. Where's the problem? That's superior cortex. Oh, girl, that's how it's done. Starting to enjoy it now. I see that look in your eye. Starting to enjoy it. That's okay, girl, as long as you now understand it. Make it easy, folks. That's what I'm saying. I just reverse whatever they say. That way you get a point. You can look up the structure later on if you want. But the point is, they say left, I said, oh, there's only one answer right. I'm out. Next question. That's it. Instead of trying to know everything about the question, with visual, just reverse everything. All right, temporal fiber C nasal, nasal fiber C temporal. Light must hit the retina by 3 months of age or you are blind for life. That means they found a time sensitivity. If light does not hit that retina by 3 months of age, you can never get that vision to come back. For that reason, you must document that a baby, all newborns, have a red reflex when they're first born. And the protocol is you must evaluate a child in the first 48 hours because you need to document all this stuff. Because if there's no red reflex, you better get ophthalmology right away. Something needs to be removed out of the way for that child to have vision. Any questions on that? Light must hit the retina by 3 months or else that child is gone. All right, you must verify red reflex. If the reflex is red, it means light went all the way to the retinal arteries. That's what you're seeing. If the reflex is anything but red, light did not hit the retina. That's why it looks gray. I've seen, most of the time it's white or usually gray or white, or they'll just say no red reflex, period. Either way, something's in the way, okay? All right, abnormalities of the eyes. Anisocoria, unequal pupil size. Number one cause of a newborn is autosomal dominant. That means mom and dad got the, mom or dad has the same problem. So whenever you see that in a newborn, they'll say, what's the next step you managing? The answer is check mom and dad. One of them has it. I've had a young lady who had it here in the program, but her mom had the same thing. Anisocoria after the newborn period is increasing the cranial pressure to rule otherwise. See that? In the newborn period, hey, we ain't worried. Outside of that, we're very worried. Okay? Increasing the cranial pressure to rule otherwise. I remember when I was going through this lecture, she was expressing her frustration. She said, man, I've been to several doctors. They would rush me off to the damn emergency room for a CT scan. I said, hell, if I don't know you, that's where you're going to. Okay, because think about it, I'm sitting there talking to you. All of a sudden I notice, oh my God, one people's bigger than the other. Folks, you start thinking, oh my gosh, there's something in her brain. I got to find out what it is. Of course, they did the right thing. Anyway, so I now with electronic medical records, it's not a problem because the next doctor can, she says, I was born with this. And he can look in the records. Oh, okay. Okay. Because if you cannot document she had that at birth, you got to rush her off for a CT scan because you got to rule out a mass until ruled otherwise. You cannot gamble with the person's life. Okay. So, and that's a core. Any questions on that? All right. Yes, Andres. Yeah, there's the lesion. You're just talking about all the different ways to mess it up. Parasympathetics, remember, come up from the neck to the eye. All right, so if you got compression here, those parasympathetics don't work. That's why your eye would then be bigger on that side. Yeah, but the point is something is compressing it. That's the key. You got to look for it. You can't just say, oh no, that's probably from birth. I don't know that. I got to scan her head. Okay, and that's what they did to her. Yes, sir. Yeah, on that side. Right. No, it's not reversed. Yeah. But remember, you give me a parasympathetic. I'm talking about brain problem right now. Yeah, then it's on the opposite side. All right, so anisocoria. Next one, amblyopia. Amblyopia is a difference in visual acuity. 20/20 on one side, 2100 on the other side. That's amblyopia. Remember the one lady with MS we saw yesterday in the question? Remember 20/50 on one side, 2100, that's amblyopia. Because that means both eyes are seeing different things. Now, how do you test that in a baby? Baby can't tell you. Simple. All you gotta do is walk in the room. If a baby has amblyopia, let's say she has amblyopia on the right side. What the baby will do is suppress information coming in from the right side. That way she only sees one visual field and everything's clear again. You follow me? The minute you walk in the room, shoot, they do that. They tilt their head to the side that's normal, away from the one that's abnormal. That's because they want to establish cycloptic vision, like a cyclops. They only want to see one eye. So they try to put that eye right in the middle. So that's how you diagnose in babies, because you can't do eye test on a baby. You can't tell you. All right, watch that head swing. I mean, that's how I remember picking one up. Because as soon as I walked in the room, the baby was sitting on mom's lap. And as soon as I walked in the room, that baby just did this to me. And I said, Mom, did she always do that? Yeah, this is a bad habit that she had. I said, no, Mom, that's not a bad habit. There's something wrong with her eyes. And so we had to evaluate her, and she did have something wrong. But see, but that's how you diagnose in babies, because they cannot speak to you. Yes, Anders. Yeah, if this side is amblyopic, then you want to go, you push your head to the opposite side, which means you're pushing towards the good eye. Yeah, the normal side, right? So anyway, amblyopia, the way you treat that, the ophthalmologist steps in, okay? Amblyopia, difference in visual field, okay? What do? They patch their good eye. Notice, that's why they like asking that question, because it sounds strange. Why we patch the good eye? To force the bad eye to correct itself. The brain can correct anything, early on especially. The brain is so flexible, but you have to force it to do it. Okay, that's why they say get ophthalmologists, because they know what they're doing. So what they do is patch the eye for like an hour a day. You know, because if you patch it for too long, hell, they'll be blind in that eye too. You don't want that. So that's why they want ophthalmologists who's trained to do it, let him do it. All right, patch the good eye, but that's the key. They'll just ask you, what should he do? Patch the good eye. And that forces the bad eye to straighten itself out. Okay? All right, that's amblyopia. Strabismus. Uh-oh, some hands went up. Hang on. Here we go. Isis, you have a question?
Hi, Dr. Francis.
Yes.
I just want a clarification,
Sure.
because the book says that the baby tilts the head towards the bad eye in order to see out of the good eye. So is the baby tilting the head towards the bad eye or towards
You-
the
wait a minute.
good eye?
Hang on,
Apologize.
let me think about this for a second. If my right eye, I might have said it backwards, my right eye is bad, then I tilt, oh, sorry, yeah, you tilt towards the bad eye, so the good eye is right in the middle. Yeah, I'd say cyclopic vision, but I did say it backwards. Thank you very much.
Thank you for the clarification.
Yeah, very good. Because remember, you're trying to establish cyclopic vision. So that means you want this eye to move to the top, because that's a good eye. You tilt towards the bad eye. That way this one is suppressed. The brain will suppress confusing information. The problem is that child will be blind in that eye for good if you wait too long. Okay? And so again, ophthalmologist is a consult is definitely indicated. And then Leslie, you had a question?
For how long we have to put the patch on?
Oh, no, ophthalmologist is the one who determined that, because he'll keep testing the eye and he can tell when the baby's starting to see normally. And then he'll
Would we
stop the
put it on the eye that it's normal, right?
Right, you patch the eye that's normal to force the eye to.
So the lazy one get better to work.
That's correct.
Right.
Right. So strabismus, misalignment of the eyes. Most common cause of newborn, weak extraocular muscles. Because remember, all the nerves are not fully attached, and that's normal. All you do is shine a light in their pupils. One will hit in the midline, the other one hits off to the side. That's normal. We see that in thousands of babies. It didn't bother me at all. Why? Because usually about a 2-month checkup is back in the middle. Everything straightens itself out. All right, but you got to know, you got to catch that, okay? Now, let me just do a couple of terms. If the eye turns in, we call it esotropia. If the eye turns out, we call it exo, as in exit, exotropia. Alignment of your eyes is not fixed in your brain till 6 years of age. So you have 6 years to fix it. What do you want you to do? Ophthalmology consult again. And what does he do? Patch the good eye, force the bad eye to straighten itself out. The brain is real flexible early on. It can straighten out almost anything. All right, so that's why we want to take care of as early as possible. So that's why when I see it in the newborn nursery, don't worry about it. I wait till that 2-month checkup. Okay, if I still see it misaligned, I say, okay, well, let's have you see an ophthalmologist. And then he'll decide when he wants to start patching it. Okay? But all the ones I saw, they straightened out real fast. By 2 months, gone. Okay? Yes. If you're older, again, and you have strabismus, you got to see ophthalmologist because you may need surgery. That means he has to cut a muscle to tighten it up. Yeah, or he'll give you special glasses to force the other eye to align. All right, so strabismus. What about stigmatism? Stigmatism is a corneal defect. You usually inherit this from your parents. So if you have stigmatism, usually one of your parents had it too. It's a corneal defect. So let's say we do what we call a straight line test. On the card, folks, there's a straight line like that. Okay? But when you show it to them, they say there's a wiggle in the middle. There's no wiggle in that line. But by letting him say where he sees a wiggle, I know it's in the middle of his cornea. All I do is just put a light there, I can see the little bump. I mean, it could be a bump coming out or it could be a dimple going in. Anybody ever seen a child wearing glasses, 2 months, 3 months, 4 months? Yeah, that's what we're doing, correcting it. So that means if their lens, so you're looking right at me. If my lens buckles in like that, you make glasses for me where the glass pops out like that. That way they correct each other. It's a straight line now. I can see perfectly until they're old enough, then they use laser surgery to fix it. So if they have a bubble, you make glasses with a dimple, and therefore they cancel each other out. The baby can see perfectly, and then do laser surgery when it gets older. All right, Ashley? Stigmatism in, as you're older, can it be from trauma? Yeah, it can be from trauma. Or it could be that as you get older, the shape of your head starts to change a little bit. And it causes the cornea to buckle. Yeah, or dip in. Or, yeah, a lot of times it's trauma because they kind of pull on it. And then you get something we have to fix. Yeah, the younger is usually congenital, in adults is usually some trauma that occurred. All right, stigmatism, that's myopia. Yes, Lauren. Yeah, astigmatism, you can say the same thing. Yeah, yeah. Myopia. Bring something closer to me, closer to my eyes, myopia. That means I'm nearsighted. That means I can see it when it's near me, but I can't see it when you put it far away. Hyperopia, the other way, farsightedness. I can see it when it's far away. When you bring it too close, I can't see a thing. It's blurry. What the heck is that all about? You know, talk in physics terms to make it sound confusing. If you got myopia, watch my hand. It means the focus of light is falling in front of my retina. I can't see it. My retina's still back here. So what do you need to do? Bring it closer so the focus of light, then here's my retina. That's what nearsightedness is. Bring it closer, now you can see it. But when it's further away, the focus of light keeps falling in front of your retina, you cannot see it because it won't focus. Okay? Whereas hyperopia, Cesar, the focus of light falls behind my head. That means I gotta pull back. That means I gotta go further away, and then the focus hits my retina, and now I can see it again. What if you have a little bit of both? That's why you have bifocals. Because you need both of them corrected. That's what bifocal glasses are for. All right. So now, here's how to figure that one out. I can't remember if I got a picture. Yep, there it is. So look at this, hyperopia. All right. Convex lens. Concave means it's coming in towards me. Convex means it's buckling out. Okay. So if you got a convex lens, that means pooched out, it makes the light come in faster. Okay. So that means you want it to come in quicker. Which one do you need to come in quicker? The one that keeps landing way behind my head. That's how you know. That's the kind of lens you need for farsightedness. Nearsightedness is just the opposite. I give a concave. This concave makes the light bounce out like that. That means it's going to focus later now. And therefore now you can see it. And like I said, if you need a little bit of both, that's called bifocals. Maybe you need to scatter it and then bring it in. And then two lenses will do that for you. Now, when you go to ophthalmologist for your annual exam, then they put that Star Wars machine in front of you. And then you, how about now? How about now? How about now? How about now? Right? What's that all about? It says, okay, I need convex lens, but how far out do I need to come out? Or I need a concave. Well, how deep do I need to make it? 1 millimeter, 2 millimeter, 3 millimeter. That's why they say, how about now? How about now? How about now? And then when you say, oh yeah, ooh, that's perfect right there. They put 4 millimeters, OD, that means your right eye. Then they do the same thing for your left eye, 2 millimeters, OS, that means your left eye. And then they set up a prescription. You get glasses that corrects both problems for you. All right. Now, what used to amaze me was presbyopia. Anytime you say presby in front of something, it means it's due to aging. That's muscle atrophy, because everybody's muscle atrophies with age. Okay. So presbyopia means you got trouble with accommodation because your muscles have atrophied. That's what aging. What used to amaze me, you see some, let's see, okay. You see some elderly people, they're wearing glasses. Then you see them at a restaurant. When you get to the restaurant, I see them take the glasses off. They take the menu and they put it right there next to your eye. I'm like, damn, why don't you just leave the glasses on? That's because the glasses is to correct one problem. This is a whole different problem. Okay, I'm serious. That's a whole different problem. So they still got the menu plastered in their face for nearsightedness. That's why in some older people, presbyopia will clear up their myopia. Seriously. Yeah, because as the muscle gets weaker, all of a sudden your lens buckles out like that. And so sometimes it can cure the hyperopia. It buckles the other way. Yeah, so anytime you ever see that, that's what they're talking about. They'll ask you, how did it happen? Okay? Any questions on that?
Also,
Karina.
some of their iPhones fixed because of the estrogen. connection.
Yes,
the
yeah,
muscular
muscle weakness,
strength.
yeah. uh-huh.
And then also another.
So, and let me just repeat it for the people online. She was just making a connection. You know, some women, because of estrogen, muscle relaxation can correct their own eye problems, because if you make muscles weak, that means the lens can change the shape and therefore correct the problem for you. Yes.
And then there's a new contact lens that you wear at night that actually reshapes the front of your eye, so that you don't have to wear glasses throughout the day. So you have like the astigmatism or nearsightedness.
Wow.
It
I didn't know
really-
that.
Yeah, they're new, the FDA just approved one years.
Ah, new lens, no, new contact lens on the market, folks, that can change the shape of your eye while you're sleeping. So that means it has certain tension to pull your lens out that way or to let your lens fall in like that, I mean, cornea rather. And therefore, you could correct either hyperopia or myopia. It's pretty slick. All right, let's see, this might be a good place to take a break. So
Excuse
there's
me,
a
sir.
straight line test. Yes, ma'am.
Lisa, did you say that, you say that myopia is can or cannot see near objects?
No, myopia is when you do see near objects, you just can't see them when they're far away.
Oh, thank you.
Remember I said, bring it closer to my eye so I can see it. Myopia, bring it close to my eye so I can see it. That's nearsightedness. So this is astigmatism straight line test. I always thought when I say you do this in pediatrics, I said, man, somebody made a fortune just putting straight lines on a card. I said, why don't I draw my own damn straight line? And it's for free. But there's a card set in pediatrics. Every pediatrician has these straight. I'm like, why don't you just draw your own line? But hey, you know, when it's cost money, yeah, that's professional now. Oh, I'm drawing my own lines. Anyway, but there is a box of cards that we picked for this. Syed, question. Syed?
Oh, is there a difference between stigmatism and astigmatism?
No, it's really the same thing. Some books say stigmatism, some call them astigmatism. Yeah, but it's the same thing. All right. Yeah, good. This is a place. Let's take our break. We start back at 9 o'clock. Yeah, because these are the most common lesions you're going to see on the boards. Because even in practice, folks, I saw every one of these. And then I realized that's why they kept testing it on the boards. So I want to go through all these lesions with you. Start back at 9 o'clock. Yes. Looks like this. Oh my God, that's TV. What do you mean on that? Yeah, the principal. The grab on webcam. Yeah, SpongeBob. Everything recognize that. That's good.
Oh, they're looking at. I'm sorry, I'm like. They love watching. Oh, yeah.
You guys don't like stuff, right?
Yeah, I've been doing that the whole time. In that. I just look up all the. Like, oh, yeah. And then, I know, I can't. Well, that was the island. You know, because all the rest of them, when I go, yeah. You know, it's really hard to see the protest. Wow. I remember all my notes. Shoot. This is my only good thing. Well, me, you should. What? I don't know. It's your class. And it's the, or not the drink. Yeah. He needs to put that on.
It's like
No, the one he drew. He drew. That one literally looks like that. I was really getting it. I was like, wow. I know. Then he comes, he's like. I don't want to. Oh, well, then I do like the way you did. Because it's like, you're on a point. Oh, I can do it. She didn't even know I. But to you, I don't know. I don't know. You don't know. You don't know how we do it. It's not. I did. There's a deal. So like. It's like I know better. Walk my home. That. Like, yeah, it's very like. It's like a very light.
Yeah, it's like, I brought my vanilla one, which is the, and then she has caramel. What is the one? It smells.
You know, something super nice. Yes. So, it's like a water, it's like 9 years old, Sephora, and like they bring the berry or like a top. It's like anything and a little solid.
Oh.
It's like for your hand, like, I like that because it's saying that you like that like either every stop they just like leave it on top. Literally called brand it's like they're leaving on the top. It was like $30. I love just that. I want to be yeah. I have a straw.
But that's something strange.
California. Really? Yeah.
But red is like, I mean.
I want to eat and. Well,
Let's see. Right. We'll see.
Oh, probably not. I'm like literally falling asleep.
That's right. That's why you.
I can't, I will literally.
And if I'm here, I'm just like,
You know, I can't.
it's right here.
I can't. Oh, really? Hey, Abby. Hey, girl.
You know me, once I get it,
She, at least respond and say hi. She heard me. Oh my gosh, shut up. Yeah, that's what she wanted. Did it work? Wait, did she respond to me? I won't even. Oh, this is from, oh, that's so cute. Yeah. Can you down or really? Yeah. This was like for planned. Yeah, I was really like, I was I know. Oh. Oh, really? It's like. I got my, I want to like start. I got my husband the. Oh, shut up. He wanted that. He got me the espresso. Oh, that's so cute. So my mom like. But I love, I don't know, I don't really like. I want to like start. I want to like, because it's good for you. Is it? Well, it's supposed to be good for like digestion. Okay, well, now we're gonna go get it. Yeah. No, I started. My stomach hurts. I was like, you know. This, from Pete, from yesterday. Dude, you're on fire. Yesterday, dude, everything. You doubt yourself a lot, you know a lot. Yeah, you do. You know a lot. No, but you just able, and then like, we pass. You know a lot, you just doubt yourself a lot. I was.
It's like, I'm like, where's my computer? I gotta.
You know what? This is. Wait.
Like, not yet.
Yeah.
2 minutes.
No problem. This was immature. Immature now.
All of the nurses see so many fuzzy surgeries and stuff. And I. Let's see, yeah, it's. And 6 months, like, a lot of them just. Like, yeah, add the card, add the card.
We have to get. Going in.
What was the thing that you said? The people. Oh.
Good.
Oh.
Just give me a nod.
Yeah.
Oh, are you? I mean, I was just trying to figure out where you go.
And I'm. I'll do it all here. Yeah.
You don't know.
Wow. If I.
Some people are impressed too.
Yeah. Oh my God.
Oh.
Yes.
Was it expensive?
It was like 40, but I think it's great.
What is it?
Wait, you bought it? Oh, it was already bound. But it was already bound.
She's going from the beginning.
You bought it bound.
Like,
Oh,
bound
you
it.
went and bound it.
yeah, I.
How
At
did
first,
you
it was
get-
like,
How did you get it?
we can get our. This one.
Thing together? Yeah, but like both books.
It was.
My dad drove with them. But it was like a here.
No way. It's amazing. I should show, I don't have.
I love it. Me too. Oh, you know what? Me too. I can't. For my computer, I don't use it for my. You guys want to know something? On the internet. Yeah, everybody. No, I just use this, but it's like all like. Oh, yeah. See, I. How do you, like, oh, I like. On here. Okay, but look, can I teach you something? So, first of all, it's an alphabet. Sometimes I. But yeah, that's. It's great. Okay. The diencephalon, where the cephalic puncture occurs. So initially you're. Well, eventually your brain, there's a term, which is why we call where the cranial nerves come. It's the ventral surface, even though it's on the bottom. This is ventral and this is dorsal. Yeah, but it's because. So ventral means anterior. So right? So if you're like this, right? This is anterior, this is posterior. And then you pull like this. So this is still technically the anterior ventral surface, even though it's inferior. Okay, this curve happens at the cephalic flexor. It's called the diencephalon. So where does the curve occur? It occurs at the thalamus, epithalamus, and epithalamus. That's the diencephalon. And when you look at this cross section of the brain, it kind of looks like a little like knob, right? Like this thing, this circle right here. That's the thalamus. This is the hypothalamus, and the epithalamus is hard to see from this view, but it's like this right here is the little ball like notch where the brain occurs. So if you just remember that the cephalic flexor, the cephalic flexor, remember that it's where that knob is. Does that make sense? Yeah. And then everything above it is the cerebrum. Yeah. And then you just remember, so midbrain stage as encephalon. Yeah. And then, so mesencephalon, and then the wrong encephalon becomes met. So STY. That's all.
I like that. I like this. I like.
You guys are burned out at night. I don't know why you all get like. Like, are you researching studying?
Okay, can you send it tomorrow?
Are you all at date?
No, we're gonna actually go get.
Start at 6. Starts. Take out at 6. Start at 6. No. Long.
Book binderies. I think what I'm gonna do is I'm gonna print this PDF out so that How do you do that? Like these slides? What I do, I open this one, see? Is this notability? Yeah, this is
You should finish it though within a
But
couple hours.
I screenshot. So what's this from? This is the other one. I have to. This is your book? Huh? This is your book? It's two copies of the book. Where's this picture in the book? No, this is my own picture. The thing what so I have two copies. And so I can, so I have to copy. So you made. Yeah, basically. And I have to copy. So then, so I can be like all. And then I can copy these, so I just very. Yeah. Gotcha. Okay.
I think it's just so we can get adventure. Yeah. I think it's just so we can get an idea of like the order. Oh, right. I wonder if it's a cross section. No, it's a kernel. Yeah, it's a kernel, sort of. Yeah. And you're doing the lateral. It literally looks like. And then this is one request this. It's like a zipper. I think it kind of zips. So you stay open at the top and at the bottom. It does. You develop like. Isn't there the yeah. Like there's that it's yeah, so you have like you fold like this cranial caudal. Yeah, cranial caudal. Yeah. So he's talking about the neural tube specifically.
So the neural tube, when it, so as you're going. Right, it develops granulated caudally, but then when it closes, it zips. So as you're holding, it zips from the middle and comes out. I'll try to find a really good video.
Yeah,
That explains it. Keep going. No, keep going. Yeah, that's fine. Keep going.
No, I mean, because I had like that, it's not really careful, like they didn't explain.
Yeah, so I. So you do. Yeah, so it's like a puddle. And so what's happening is like you develop like caudally organ wise, which is like, it kind of makes sense, right? Brain first, then the heart, and then the kidney. When you're, yeah, but then when you're like the embryo, what happens is things are migrating, so your neural tube is like open tube. And as the embryo is folding, it kind of comes together, like it forms like almost like it's like a flat sheet, right? And then when it folds, it folds and zips midline, and then kind of. Okay, so imagine a piece of paper.
Basically,
Like it's a paper, right? And then you bring the middle together here, and then this, yeah, exactly. Does that make sense? Yeah. And then that's when you know.
Ajá, te veo.
again? No, Steve.
Just messing with you. I see you in the camera.
Hi.
Yeah, then it, as it. So, like. I'm making funny. That makes sense, yeah. But if I have. Yeah, so I'll try to find it. There's like for specific for Denver knowledge that help people visualize like that rotation. They're on YouTube. I'll send it to you. I'll find everything. Okay, I'll link them. It's just about like, oh. He's not.
I'm so glad Jesse didn't come today. Late.
Not like this, but it's like this. So it does like 90 degrees, then 180 degrees as it comes back in. It doesn't rotate all at once. And then as it comes in, the sequence swells, so it falls to the bottom. And that's how you get like your superior pull. So it starts like this, it comes on like this, and it goes 90. Right. then it goes 180, so if I go 180. So it's like this, and then comes up and second swells down, and everything falls. Lines. That makes sense. What's better? Yeah, but yeah, it comes out all 1, 2, right? So it comes out like this. And yeah, that's what I did yesterday. But yeah, like all of this. Really, really good. Oh. Just to visualize, like obviously. It's very like. But I have lost an equalization, so. As we all. Yes. This is like real, it like looks real. And it's hard to find videos that are good for relative. This is, there's a place from here, Lake, it was like. They changed it, but this is what it was like. But then to the total. It's very shallow. It's a so they get have some tradition. And oh, it's like this. Where they'll like jump in it, like after it's like it's
Oh, that should look better.
so yeah, so they like changed it. It's more like a. But this is before it was. But yeah.
Bueno, por favor, que no puedo comer siempre para.
That's.
Yeah. Oh, that's. Yeah. Have you noticed that? Yeah. See, I haven't. I had conversations. Yeah. What's
All right, let's go through the visual field defects. All these are very common, folks. And that's why these are very commonly seen on the USMLE and COMLEX. Because you're gonna see patients come into your office with these complaints. So this is a good place to start. You see where the arrows are, that way you can visualize where the lesion for every one of these is. All right. And then we're just gonna go through it one at a time. 6 popular visual lesions. So you see the first one is by lesion one nerve, optic nerve, then you're blinding that eye. That's pretty straightforward. All right, anyway, white reflex. You have a white reflex? That means the light is not hitting the retina. It's not hitting the retinal arteries. And number one reason, cataracts. What is a cataract? A pacification of your lens. That's when they want to make it an anatomy question. Does not allow the light to hit the retina, so it has to be removed right away. Remember, you got 3 months, and that light must hit the retina. There's increased incidence if you got glucose or galactose problems. Remember, sorbitol from glucose, galactitol from galactose. All right, and the enzyme who makes those things, Sandeep? Aldose reductase in case has, which means sorbitol dehydrogenase got overwhelmed. So idiopathic, number one reason for cataracts, it just happens. We just see it all the time. But if they, most times I've seen the question, they want the glucose. That's why I put that up there. So diabetes or galactosemia. And if they want infection, rubella, the one that's most notorious for causing cataracts. Okay, so white reflex. Retinoblastoma is rare, but it goes with the RB gene. If you remember the RB gene as associated with Ewing's osteosarcoma, that's what they usually like to ask. What other cancer you have to watch this child for? This is the one. I remember there was a case on CNN one time. This is when Facebook, was it Facebook? Yeah, Facebook had just started. And, you know, people were posting pictures of their children, right? And this mother posted a picture of her child, and her child had a white reflex in one eye. I think it was a 4-month-old baby. And was it 4 months? Maybe it was a 2-month-old baby. So anyway, so there was a medical student across the country who noticed there was a white reflex in one of the eyes. And, you know, sent her a message, ma'am, I think you ought to get this thing checked with your pediatrician. And sure enough, the child had a retinoblastoma. But obviously, that means the pediatrician had never done an exam on this baby. That's kind of a little embarrassing, because now you're all over CNN that you don't do good exams on your children. So anyway, I'm sure it made him look real bad in his community. But that's why you're supposed to, it all it takes just flashlight in the eye, folks, and then you see red or not see red. Yes. Huh? Yeah, it's asymmetric. One side is white, the other side is still red. Yeah, usually you're not gonna have 2 retinoblastomas. All right, monocular blindness is when you lose your one optic nerve. Newborns, or the light not going in, so newborns is cataracts, retinoblastoma that we just did. Whereas in children, is actually the nerve, optic nerve glioma. And they usually want a syndrome. That's why I give you the 2 most common syndromes, neurofibromatosis or MEN3. All right, they both have glioma. In adults, they love this one, embolic phenomena. TIA, number 1, 90%. Remember the TIA, oh boy, there's an allergy acting up. Give me a second, sinus drainage, I hate when that happens to me. Because it changes my voice. I feel like I'm going through puberty again. Yeah, could you get it? The thing of water, man, goodness, okay. Good. Oh, yeah, I forgot my man got me some water right here. Yeah, I totally forgot I had some water, thank you. Yeah, ooh, that feels good. Good here, that means I need some more.
Oh, my God.
No, as long as I stay away from it, I think we'll be okay. Okay, forget it, let's go. I got electric wires here, last thing I need, splash water all over electric wires. All right, adults, TIA. If you have TIA, what percent stenosis of a vessel do you have, so? Huh? No, remember, events occur at 90, that's stroke. This would be 70%. So TIA, it's called amaurosis fugax. If you remember the way I described it, the person feels like a curtain just went over the vision field like that. That's a clot going into ophthalmic artery. Okay? There's acute retinal artery occlusion. How do you know that? The retina is white, but the macula is cherry red. Remember cherry red macula, because it has its own blood supply. And then it could be painful. Retinal vein occlusion, the veins are all backing up, blood just engorged. It looks like a thunderous sky is the way they like to describe it. You know, like a thunderstorm up in the sky, just because all the veins are dilated and full of venous blood. So definitely it's easy to separate all 3. Elderly, macular degeneration, number 1 cause of blindness. That's because the macula has the most fragile and smallest vessels, so they get occluded first by atherosclerosis. And then you lose your macula. How do you lose your macula? They always lose central vision first, because the macula is central vision. Nolan. Yes. I said it's, the stroke will occur at 90. The TIA occurs at 70. Remember? Yeah. No, the event is when you actually have a stroke. TIA is a warning that you're at risk for a stroke. That's why. Oh yeah, good question. So what medicines would you put them on? Aspirin, yes, but not clopidogrel. You remember the second drug? Aspirin and anybody? Aspirin and statins. Remember, you start out with secondary prevention. Yeah, you're not gonna wake up the plaque is already there, but you're trying to stop it from getting any worse. So that's how I remember aspirin, to stop the platelets, and statins to stop cholesterol from depositing. All right, any questions on monocular blindness? Okay, that's lesion number one. Lesion number two, optic chiasm lesions. Optic chiasm, all right? Which fibers cross at the chiasm? Nasal fibers. Remember, the temporal fibers go straight back. Nasal fibers, they cross. And what's underneath them? The pituitary. So it's almost always a pituitary mass and occasionally pineal. But pituitary is number one. So then we talk about microadenomas and macroadenomas. Microadenomas will have galactorrhea and amenorrhea, as we spoke of, but no visual problems. That means it's too small to encroach on the optic chiasm. So Ashley, chiasm, the mass is too small, so it doesn't really push on it. And that's why they still have just a galactorrhea and amenorrhea, all right? Because you're blocking the dopamine fibers, okay? But once they get visual by temporal hemianopsia, that's called macroadenoma. You have to treat that and you get taken to surgery, okay? How do you treat a pituitary tumor? What drug do we give them, Miguel? Huh? What drug do we give them to treat the galactorrhea and amenorrhea for pituitary tumors? It's not called dopamine, though. It has a different name. So Zara will help you on this. Bromocriptine is one we used to use. Remember now, cabergoline beat out bromocriptine. So you got to know, you got to use that one now. All right. So microadenoma, cabergoline only, and just observe every 6 to 12 months with another MRI. However, if they have visual problems, cabergoline right away, and then plan to do transsphenoidal surgery. Okay. Any questions at all? All right.
Yes, I have a question.
Yes,
If-
who speaks? Who's that?
This Ryan.
Oh, okay, go ahead, Ryan.
If you give the patient cabergoline, will they start to have is it extrapyramidal symptoms?
Extrapyramidal symptoms is when you block dopamine. Cabergoline is a dopamine agonist. So
So
you'll
they
have
have
symptoms which are consistent with dopamine, like what?
Is it Parkinson type symptoms?
No, Parkinson's is when you're blocking dopamine again. I'm giving you a dopamine agonist.
Oh,
So then all you have to think about what does your body do with
excitatory.
dopamine? Yeah, so what symptoms do you get from dopamine? Like what?
Increased heart rate.
Yeah,
blood
because dopamine
pressure.
gets turned into norepinephrine. You get a lot of sympathetic tone.
Mhm.
But unique to the dopamine is nausea and vomiting. Your vomiting centers are going to be stimulated. Psychotic symptoms, because that media psychosis. Okay, you understand?
Yes.
All right. All right, so optic chiasm lesions complete. Next one.
Excuse me.
Oh, wait a minute. Yeah, I just realized you had your hand up too. All right, go ahead, Mabel.
Please, what do you say that differentiates between TIA, acute retinal artery occlusion, and the retinal vein occlusion? You said was wanting to differentiate it.
Oh, boy, I told you there's something wrong with that sound system. I just went through all three of them for you. All right, so all right, are you able to hear me?
Yes, sir.
Before I go through this, all right. Let's see, go back. TIA, the person will tell you there's a curtain that went over their visual field and then it went away. Acute retinal artery occlusion, I told you their retina will be white, but they have cherry red macula, and it can be painful. Retinal vein occlusion, I told you the retina will be blue, and it looks like a thunderstorm in the sky, but that was just engorged veins. Did you get all that?
Yes, sir.
All right. All right, so optic chiasm lesions. Now we're going to number 3. It's the optic tract. Okay, again, when you're drilling with somebody, kind of go through these with somebody so you can visualize where the lesion is each time, and therefore you can see your differential. All right, optic tract lesions. You got ipsilateral temporal fibers, and then contralateral nasal that's crossed over that side. And that's why you get what they call homonymous hemianopsia. That means you lose the opposite visual field, but half on each side. So if you lesion my left, I'm going to lose my left nasal field, but right temporal field. Okay. All right. Homonymous hemianopsia is what it's called. Most common cause, cancers and tumors. What's the most common tumor of the brain? Austin. Not craniopharyngioma. Tumor of the brain, most common cause. Ashley. No, metastasis is the most common cancer of the brain. I said tumor. Tumor is benign first. All right, Jess. Meningioma is not a brain tissue. That's meninges are outside. Yeah, inside. No, what else? Say astrocytoma. Astrocytes are the most numerous cells. Astrocytomas. Remember, to name a tumor, Ashley, you say, what's the most common cell type? Astrocytes are most numerous. So astrocytoma, okay? Most common cancer is metastasis. Most common intracranial tumor is meningioma, because meningiomas are more common than astrocytomas, but you have to say intracranial. If you say brain, well, meninges are not part of the brain, they're outside of it. All right. All right, so we did the next one. Quadranopsias now. Quadranopsias are pie in the sky. Easy, just reverse both words. That's what we did at the outset. Superior, a right superior quadranopsia is a left inferior cortex problem. That's all you gotta do, folks. That's all I do. It takes 2 seconds, you get a point, go to the next question. Quadranopsias, again, usually due to tumors. What unique information does each cortex contain? That means each part of your cortex, what unique information do they contain? So we're gonna go down through, we're gonna go through the cortex and then go down through the brain till we get back to the medulla and spinal cord. Syed, you have a question?
Yes, just regarding, I know you said just now to reverse the directions, but if like the question asked about like which lobe, do all these like go to the occipital lobe?
Yeah, they end up in the occipital lobe, but you can do a quadranopsia in the posterior, let me see, they'll say posterior temporal lobe or anterior occipital lobe. You know where Myers loop is? Yeah, you can say posterior temporal. Yeah, so that's 2 ways of saying the same thing. All right.
Okay, thank you.
What unique information does each cortex contain? Here we go. Frontal lobe. Frontal cortex, folks, pay attention because this is how you find your lesions. Precentral gyrus has corticospinal tract, so upper neurons originate from here. So you see like hyperreflexia, clonus, what's the other one? Spasticity. So upper neuron is involved. The most original information is personality and abstract reasoning. Personality. When somebody, a wife usually brings in a husband and says, man, he's just not his old self. That's personality change. A little old lady in the nursing home, the staff are complaining, man, she's just not herself anymore. I don't know what's going on with this woman. She got a frontal lobe problem. Yes, we used to miss frontal lobe seizures, frontal lobe strokes, frontal lobe tumors in elderly, because when they start acting crazy, everybody just thought, oh, crazy old lady. Yeah, but she's not normally that way. She's normally a real quiet, docile, peaceful person. If someone starts acting differently, and they normally do, you got to know they're trying to tell you the personality's changed. There's a frontal lobe problem. Make sure your answer better have frontal in it, or else you're just wasting your time picking something else. All right, the other one is abstract reasoning. How do I know that one? They don't hear anything profound in your words. You say, what does it mean when somebody says, don't cry over spilled milk? They look at you all perplexed, like, you don't know what that means, Doc? It means we got no milk for cereal. They look at you like you're the one who does it, who got the problem. But they don't hear anything profound in it at all. Okay? All you do is give one proverb, and that's all you need. All right, so that's frontal lobe. Any questions on that? Again, I'm just giving you the highest yield information because all I need is one of them. I don't need all of them to be there. And that's what they do on the test. They don't give you every feature. You just got to know one, that if one of those is on there, it's definitely frontal lobe. Okay? That means all the rest of the stuff, fluff. All right, frontal lobe lesions. You need to know atonic seizures. If you have a seizure that goes across your frontal lobe, they hit the ground like a wet noodle. That's because now they have no corticospinal tract. They lose all tone to their body. Corticospinal tract maintains the tone in your body. So without it, boom, drop to the ground. Atonic seizures. And now, how do you know when somebody's having a generalized seizure? They move all over. You know, I move all over when I'm dancing in the morning. You trying to tell me I'm having seizures? Yeah, you got it. Thank you. Loss of consciousness. That doesn't mean move all over. I told you guys, it's not about what's going on in the seizure. Loss of consciousness is what tells me whether it's generalized or not. If the patient can tell me what happened, then they were conscious. then it was partial. Doesn't matter what part of the body was shaking. Okay, but if they cannot tell you a thing, that's how you know it's generalized. All right, generalized seizures in children, drug of choice. Karis, take the first one. Now, we've gone through this drill many times. Everybody ready? Because you don't know if I'm going to be pointing at you. All right, phenobarbital for children and adults, Mitchell. Phenytoin, temporal lobe seizures, Jess. Carbamazepine, mixed amyotonic seizures, Bailey. Not D something. All right, Ida, valproic acid. Remember, mixed sodium and calcium. It blocks both. And myotonic, muscle contraction, blocks calcium. Okay. All right. Let's see. Febrile seizures, Austin. Rachel. And Nolan. And Amy. And Reed. And Sandra. All right, let's go back. Okay, Gustavo. Tylenol. Now we've drilled this a bunch of times on these morning questions, folks. I told you one day it'd be your turn to tell me all the answers. We went through them. We drilled it a bunch of times. Every time a seizure came up, we drilled it again. That means everybody's got to know all of these drugs of choice because it's going to be on your exam. All right. So anyway, so mixed up my time. What about infantile spasms, Gloria? ACTH injections, status epilepticus, Ida. Diazepam, the only one that comes rectal suppository, in case you haven't started an IV yet. All right, so everybody should know all those drugs now. All right, but anyway, atonic seizures. Dementias, we talked about a bunch of them. Alzheimer's, remember they have changes in personality when they start getting older. Pick's disease, remember frontotemporal dementia, they act weird. Their family just admit she or he's not herself anymore. All right. So dementias can have frontal lobe lesions as well. Schizophrenia. Well, they're definitely acting weird. So that's how you know frontal lobe is involved. So somebody had a bunch of extra money left over from a grant, so they decided to do a CT scan on schizophrenic patients who are perfectly healthy, well controlled on medication. Say, let's look at the frontal lobe and see what we're going to find. Two things they found. Number one, the ventricles are dilated. We don't know what that means because they weren't having any pressure from it, but the ventricles were dilated. And number two, there was an asymmetry in their, there was loss of asymmetry because the right brain is not supposed to look like the left brain. The sulci and gyri are different. But in schizophrenia, it starts to look almost identical. We don't know what that means either. Okay, but I've seen questions where they will ask you, what are you going to see on a CT scan in this patient with schizophrenia? Okay, so you don't need to know those two things. There was a finding from years ago. Yeah. All right, Karen. Pick's disease is frontotemporal dementia. That's why they act strange before hallucinations. Yes.
I explained that once. It was in years like just like the schizophrenia thing that the reason she thought it was like dilated and then they kind of looked the same like because there was a little atrophy. So which I think it kind of makes sense. So it was just they were kind of smaller. So just look, it was apparent. So like they looked like they're
Maybe that, so that means they appeared symmetrical.
Yeah, and then also like the
Because of atrophy. It's possible.
Stuff.
Yeah.
They just kind of look more similar.
Okay. So sounds okay. It's possible. Yeah, that would definitely explain that enlarged ventricles. Yeah. Okay. Yeah. All right. Think about years ago, we used to do frontal lobotomies on criminals. That means if you were guilty of killing somebody, they would carve out your frontal lobe. That way you would change your personality. You would no longer be a criminal. But these guys were playing with dolls in jail. You ain't gonna last too long in jail playing with dolls. So anyway, there was a Supreme Court that struck that down. Said man should exercise choice. You can't just carve out everybody's frontal lobe for being bad. That means you're saying that nobody can ever be rehabbed, and that's not true. So they struck it down. All right, but just so you understood what they were doing. Yes.
Wouldn't that make their behavior even worse because filters are
That's one side effect. Filter being gone. Yeah, but frontal lobotomies always change their personality. That's all they cared about at that time was just changing their personality from criminals to something else. Anam, you have a question?
Yes, sir. So this was when we were talking about the pituitary tumors. It mentioned bromocriptine and cabergoline. Is cabergoline preferred over bromocriptine these days?
Yeah, cabergoline beat up bromocriptine in a head-to-head randomized trial.
Yeah, and then the second thing you were talking about frontal lobotomies. I don't know if you've watched One Flew Over the Cuckoo's Nest. That's what they did to Jack Nicholson at the
Yeah.
end.
Oh, man, that was from way back. Yeah, I remember.
I
that
know,
movie.
that's a great movie though.
Yeah, very good movie.
Not
Yeah,
to
that's what
mention
they
my
used to
name.
do back in the day, just do a frontal lobotomy so they would change. All right, anyway, that's frontal lobe lesions, says mere personality, abstract reasoning, and corticospinal tract. That was my 3 clues. Temporal lobe now, temporal lobe, hearing and balance. Why? Because 7 and 8 go right through the middle of frontal lobe, I mean, the temporal lobe. It's rare you have a temporal lobe problem without having 7 and 8 get clipped. So hearing and balance are gonna be off. Next, hallucinations. Hallucinations are stored in the temporal lobe. What neurotransmitter causes hallucinations? I said, what neurotransmitter causes hallucinations? No, not serotonin. Lillian. It's dopamine. Serotonin controls them. So everybody hallucinates. I mean, I told you that before. It doesn't mean when you hallucinate, you're psychotic. Everybody hallucinates. All right, but then serotonin says, no, that was just hallucination. Just like, you can walk through a park and or especially downtown. I mean, many times I walk downtown, I just want somebody to call my name. But that's a hallucination. That's a dopamine fire out of the blue. And then you realize, nah, nobody called me. And just keep walking. That's serotonin. All right, next, short-term memory. Superior temporal lobe, remember hippocampus. Temporal lobe. These are all the clues for temporal lobe. All right, short-term memory. They walk into the kitchen, they forgot what they went in there. Okay. And then posterior temporal lobe, remember Wernicke's area. They cannot understand spoken or written language. So when you're speaking to them, they're looking at you, concentrating on what you're saying, but they can't really understand what you're saying. But their speech is totally clear. Okay. Temporal lobe. Any questions? What infection like to attack your temporal lobe? Michael. Yeah, it's a herpes. If they want infection to cause a problem, see, now you can put the herpes in there. All right, very good. And what's the drug that drives the temporal lobe seizures, Jess? You're the same person I asked a few minutes ago. All right. Oh, okay. No, it's carbamazepine. All right, that's temporal lobe. Temporal lobe lesions. Again, I tried to give you guys examples of each one as we go. Temporal lobe seizures. Why do you think they hallucinate like crazy? And temporal lobe seizures, they always have hallucinations before they start shaking. All right, I had one young girl, first she came in, I think she was about 10 or 11. She had macropsia. She saw humongous spiders on the wall right before her seizure. That's what the term is, macropsia, things are bigger than usual. And then when I started talking about, hey, that's gotta be temporal lobe seizures, and her mom brought her in. And her mom said, you know what, I think my other daughter got the problem too. I said, what's going on? So I said, well, bring her in. She had micropsia. She would see tiny spiders all over the walls right before her seizure. I said, that's the same thing. And then mom said, wait a minute, I think I got it too. I said, okay, well, let's see, take a look. Got more history? Mom had it too. That's the first genetic series I've ever seen. Mom and 2 daughters, all of them had it. Mom would have absence, staring spells. She would just blank out and then end up somewhere and didn't know how she got there. Her husband divorced her because he thought she was cheating because she was always someplace and couldn't figure out how she got there. Sounds like, yeah, a likely story. She lost her marriage over it. She was so happy when I figured out what it was and treated them, they were back to normal. It was amazing, but it was the best case I ever had of temporal lobe seizure being genetic. I didn't even know it could be genetic.
No, I was just gonna say about the genetic thing, because it was so interesting when I was telling my mom about like how she was probably like, why are you telling me this? About the seizures, so they can be on like the different parts of your brain and you can have hallucinations.
Yeah.
Things little.
Yep.
She told me about like just the town where she grew up. It was just like there's just like a little bit of people, so like they like marry each other, I guess, whatever. I don't know. It's weird. But I guess there were a lot of people who started. They said they were like there was witchcraft because they would all see like
they would see things little and then they would get lost and then eventually they would end up drowning themselves because they were like, they didn't want that to happen again. So it was like a story. So like the villages
Oh, wow.
were
So
like,
a village where a bunch of people had temporal lobe seizures and they didn't know, they thought it was witchcraft. Yeah, so they thought somebody was putting some hex on you or something. Yeah. And it shows you how medicine progresses. Yeah, a lot of people had explanations. I mean, in Nigeria, when any illness happens, they swear somebody put a witchcraft hex on your family. I'm telling you, I got to deal with this every time I go. I said, no, it's not witchcraft. It's called this rash or it's called this. But every time, I mean, somebody put a hex on your family. That's why your dad died. No, it's called heart attack. That's what killed him. I'm telling you, man. I'm always trying to fight with them about this stuff. Everything's a witchcraft to them. Yeah. Yeah, I know. A big sudden death means somebody put a hex on your family. Anyway, but that's the way it goes. All right, anyway, that's temporal lobe seizures. Next one, schizophrenia. Schizophrenia, they hallucinate all day long too, right? What kind of hallucinations do you get? What kind of hallucinations? Auditory, visual, or tactile? Yeah, auditory is over 90% of the time. Occasionally visual, but tactile is rare. What's the most common cause of tactile hallucinations, Ina? Well, alcohol withdrawal, number one, and then cocaine intoxication, number two. All right, so schizophrenia. Dementias. Remember frontal temporal dementias. As soon as that temporal lobe is involved, all of a sudden they start hallucinating in Pink's disease. They act weird, frontal lobe, then they start hallucinating later, temporal lobe. See? What about drugs? Drugs cause hallucinations. See? SSRIs. People hallucinate on SSRIs or amphetamine. They hallucinate. Okay. Which amphetamine do we use to treat ADHD in children? Amy. Which amphetamine do we use to treat ADHD in children? She forgot, read, help her out. Methylphenidate is a drug of choice. Which amphetamine causes superhuman strength and violence? Solange. Who? All right. On the sort? ECP. Colorful hallucinations. Sabu. LSD. All right. Superhuman thirst. Edna. Oh yeah, I knew the answers. Everybody else is answering. Till it came to me. I told you something happens once you hear your name. It's not the same. All right, Akshay. That's ecstasy, MDMA. All right, so anyway, that's drugs. Temporal lobe lesions. Amphetamines, remember? Again, you've heard this twice already. It's the third time now. Taken up presynaptically causes release of catecholamines. The best clue for amphetamines, remember, vertical or rotary nystagmus, right? Serotonin controls hallucinations. But if I give you too much, I throw off the balance. You can still have hallucinations. Yeah. All right, amphetamines, here they are again. Used to treat ADHD, methylphenidate is number one, and then the other three are backup drugs. Over the counter for weight loss, I told you was a watered down dexedrine, which is Dexatrim. Cause hallucinations, these are the three. We just went over their clues. Any questions on any of these? Again, it's drilling, folks. There's no magic, but you got to drill if you want to remember it. Yes.
She asked like serotonin, so excess, is it because it's like a CNS stimulant? So it
Right. Right. Yeah, so serotonin can stimulate the brain and set off hallucinations. Again, they got to be a balance with everything. Yeah, if you throw off the balance, things happen.
Sir, I had a question.
Oh, Adam, go ahead.
Yes, sir. So comparing methylphenidate to Adderall, does methylphenidate have is it the most potent one compared to Adderall? Because I know in the notes it's saying it's used for weight gain and growth also, right?
Yeah, I mean, it can cause growth problems but that's why we monitor their growth chart.
So is
Because
Adderall a
methamphetamine
better
can increase
choice?
appetite. Is Adderall do what?
Is Adderall like lesser when it comes to? like,
Yeah, it's
potency?
less effective. Yeah, methylphenidate has the most literature behind it for being effective.
Okay.
Adderall came out after methylphenidate. All right, but for some people, Adderall works better. That's why you start with the most effective. If it doesn't work, then you can switch to one of the other ones and try it. But you always start with the most effective one first. Yes, no.
Yeah, just another Adderall question. Is there anywhere it's used first line? I show a lot of people on it.
I know. Is there any place where Adderall is used first line? No, Adderall is not supposed to be first line for ADHD, but some people choose to use it. But remember, Adderall is way more addicting than methylphenidate. That's why you don't start with the one that has such addictive potential. Methylphenidate is better to start with, and it's effective for so many years. That's why we always start with that. All right, that's why, again, when it comes to test questions, that's why I want you guys to make sure you know what the literature says. And that's what I'm quoting, not what my attending does. Everybody said, oh, my attending, you gotta be careful. Your attending can do whatever he wants to do. But does it follow literature? The problem is, a lot of times it does not. It does not. Okay, and that's why then doctors get in trouble. If something goes wrong, all of a sudden, the lawyer will say, why are you using this, doc, when this is more effective? All of a sudden, now you're in trouble. All right,
So is serotonin causing hallucinations or
dopamine is one that causes hallucinations, and serotonin normally controls them for you. However, if I overwhelm your system with too much serotonin, it can stimulate your brain, which means hallucinations can still occur. That's why you're throwing off the balance. Control means tells you that that's not real. Yeah, just like when you hear a voice, and then the voice in your brain tells you, oh no, that's not real. Everybody tells about when they're walking along, they swear somebody called their name. And then the brain tells you, no, nobody called your name. That's serotonin. Right. Yeah, but they'll just say which one causes hallucination. When they say causes hallucination, then you got to know that's usually an excess of it. Because if everything's balanced, you don't get any problems. That's the problem. When who causes hallucinations? It's excess dopamine, but the question was said, who causes hallucinations? It's just dopamine. Yes, it's going to be an excess, but that's not what. It's not necessary for them to say that. They just said which one causes hallucinations. Always say dopamine. Yes, but you have to say dopamine. No, you have to say dopamine. Because dopamine normally causes hallucinations, serotonin normally controls it. So that means when they ask me a question, that means I got to pick the one that's normally the best answer. That's why they always say pick the best answer. Not that the other guys can't do it, but which one's the best answer? That's all you do. All right, no problem. Other SSRIs, fluoxetine, which is Prozac's been out the longest, has every indication there is. SSRIs have a lot of indications. Give me one indication, Michael. Then we use SSRIs. ADHD in adults. Karina. Phobias. Cesar. Depression. Saba. Anxiety, all the anxiety disorders. Years ago, when they suddenly exploded in the market for anxiety, I was like, well, how is serotonin going to treat my anxiety? And then I read some literature that said they had just found out serotonin actually mitigates anxiety. That's just like it controls hallucinations, serotonin controls anxiety too. The more serotonin you have, the less anxiety you actually perceive. I said, oh my God, that's why all of a sudden it's indicated for everything. Because it just happened in a real short time. Bam, next year was for everything, SSRIs now. And I said, wait a minute, did I miss something? Okay, yeah, it usually means you missed something. That's what I said. That's what makes me go back to literature, go figure out something, what's going on here. That means there's an action I don't understand yet because it didn't make any sense to me. All right, so anyway, that's the SSRIs. SNRIs just do serotonin and norepinephrine. Obviously, they have a little more side effect than just SSRIs. The main side effect, SSRIs, Ashley? The main side effect of SSRIs I got to worry about? Rachel? And not so much decreased libido. That's a different term. Nolan? Yeah, any of these drugs can cause suicidal ideation, just so you know. But there's, all right, Meha? Priapism is only trazodone. What's a common side effect of any SSRI? Paul?
I was thinking
Not serotonin syndrome. That happens after years of being on it. Ida, remember anorgasmia, difficulty achieving an orgasm. All right, and anytime you have sexual dysfunction on an antidepressant, what drug am I supposed to switch to? Bryce. All right. Bryce, you have an answer?
No, I forgot.
All right, Sheena,
Bupropion?
yes, it is bupropion.
Okay.
I forgot, is it bupropion? All right, that means you.
Sir,
it
please,
was
what's the
being fighting its own
question?
subconscious. What?
What's the question, sir?
Boy, I told you there's something wrong with that system that she's got. All right, the question was, what drug do you switch to when you have sexual dysfunction on any antidepressant? What's the
Okay,
answer?
thank you. Okay,
What's the answer?
bupropion.
Yeah, bupropion.
Yeah.
All right, trazodone has priapism as a problem. All right. And now parietal lobes. You got dominant, non-dominant. Now, dominant parietal lobe is where all your long-term memory is stored. I summarize it for myself and saying it's everything you've learned since kindergarten. There's 8 phases for all of them. All right. So I'm not going to try to memorize 1,000 words. Okay. But if you can't do something I know you've learned since kindergarten, you can't tell me your name, your gender, you can't tell your shoes, can't tell me colors, can't tell me your address, you know, you can't add numbers. Remember, there's all kinds of words for that. Agraphia, alexia, whatever, agnosia. They'll have A in front of it. It means you can't do it. I just summarize it. If all you gotta do is tell me one thing that I've learned since kindergarten, and if a patient can't do it anymore, I'm telling you, dominant parietal lobe is your answer. But please don't try to memorize all those words. You're not gonna remember them. All right, now 90% of people are right-handed. That means the left parietal lobe is the most dominant. Everybody follow me? Okay, remember things cross. Where do things cross? In the brain, they cross in what we call the corpus callosum. So fibers to the right go left, fibers to the left go right. So left dominant lobe sends fibers to your right hand. That means all your long-term memory is stored in that left parietal lobe. If you want to cross fibers in the spinal cord, it's called the anterior white commissure. One more time, 90% of people are right-handed, which means the most common dominant lobe on them is which one?
Left.
Is the left. Everybody clear? However, 10% of people who are left-handed, 90% of them have left parietal lobe dominance, which means 99% of people are left parietal lobe dominant. Only 1% is right parietal lobe dominant. Everybody understand that? Because they're trying to fool you and say, well, left-handed people, you're supposed to know it. It's still left parietal lobe dominant. What that means, therefore, Metro, is that their fibers come straight down like this. You understand that? Let's see if you guys really understand. If I'm left-handed, where am I getting my long-term memory? Where's it stored? Maria says. Long-term memory stored where? Left what? Left parietal lobe. So that means I get my information straight down like this. Okay? In the old days, folks, they thought if you were left-handed, there was something evil about you. In my country, Nigeria, you don't reach out your left hand to shake anybody's hand. You're actually insulting them. I had to learn that the hard way. I was insulting all kinds of folks. I didn't know. I totally forgot. I left when I was 8 years old, so I had to relearn a lot of things. That's because they still have that belief. All right? That there's something negative about a left-handed person. So they would make you become right-handed. We had a student here a few years ago. His mother made him do that. They switched. Think about this. If I have all my long-term memory stored in my left hand, that means how to make the letter A or B or C is stored there. And then you want to make me right-handed. His right hand doesn't have access to that. Everybody see? You have to start all over again. They start writing like they're back in kindergarten. He was a grown man. But his mother did that to him. Of course, mom didn't know. This was a while back. And so now he's ambidextrous. He can write with whichever hand he wants. But that's what problems it creates. It makes the child look like they're, or the person look like they're back to being in kindergarten again. 5 years old, trying to learn how to trace the letter A, trace the letter B. That's because you don't have access to that memory anymore. Okay, because it's on the other side. Now, if you have absent corpus callosum, then fibers are naturally on the same side. You understand that, lady? You understand that, Queenie? Then you're a normal person. That means your brain started out that way. So everything's perfectly wired. You know what that person's called? Ambidextrous. People who can do things with the right and left hand, and they never run into each other. I remember seeing one on TV. This guy could write 2 letters, you know, dear mom, dear dad, and the letters would be going around, going this way. Both hands, like that. That's complete corpus callosum, was never developed in embryo. So everything's perfectly wired on each side, and they never collide with each other. So, but if you try to do it, if I try to write my left hand, I'm right-handed, it's gonna squiggle, it's gonna be all over the place. Why? Because I'm trying to concentrate on how to make the letter A, because memory's not on that side. This hand has to, I gotta somehow override it and make a decent looking A, but it ain't gonna look normal. Okay? Absent corpus callosum, ambidextrous. Bailey, you ever seen somebody with absent corpus callosum syndrome before? No? What about you, Jazz? You ever see one? No? That's a trick question. You guys have seen it a bunch of times. You just didn't know it. You know who the absent corpus callosum, my favorite one? It's called a drummer in every group. How can a drummer, each hand, each leg is doing something totally different? And he's having a conversation with the bass player. And man, where we're going next? Oh yeah, St. Louis. Oh, I love the barbecue, man. You know, hey, you gonna hook me with your sister, man? I know she was checking me out last night. I mean, come on, man, hook it up. I mean, you know the conversation. And then it's a beat. Now I like that because I was fascinated with drumming, and I tried to take drumming lessons. When I first started Past Hunger, I was taking drumming lessons every afternoon. I was in there talking, and this guy was like, "Yeah, just do that, like, man." I said, "What? Just do what?" Yeah, just like the. I said, "Dude, I'm not wired like that." Now he doesn't know, he has no corpus callosum. He just da-da-da. He doesn't even think about it. He's playing the drums while he's busy talking to me. Me, I got a concentrate. You know, here, I think I took the lessons for over a year. You know, paying every time, pay. At the end of the year, boom. I said, okay, this ain't gonna work. I'm just wasting money. My corpus callosum is swollen. There's a dampness right now. So I finally gave it up. I still got drumsticks in my car because I'm fascinated with drumming. I said, man, after corpus callosum, because the guys who were the best drummers, they were wired that way from the beginning. And that's why it's so easy for them to get in front of a drum set and just play. Like Van Halen, the Van Halen drummer, one of the best drummers I've ever seen, man. Oh boy. Anyway, let's see, some hands are up here. Hang on, hands first. First person, Bryce, you have a question?
Yes, I was just wondering if there was any long-term study on people with no corpus callosum to see if they would develop any kind of brain problem in the future.
Yep, there was no problem. Completely normal.
Okay.
I'm sure they didn't follow for 70 years, but you know, all the years they followed, there was nothing abnormal about them versus the normal population.
Okay.
Yeah. All right, Leslie, question.
Yes, I have a question. Like, if you have a right hand person, and then you, like, for example, like I was like in a Catholic school, and I was left, and they make me right because of the.
Yeah, see, the Catholic Church used to think the same thing. Yeah.
So, and like I write with my right, but I lost my left like capacity, but like you still have difficulties sometimes with left and right?
Yeah, that's because they forced your brain to try to become a right-handed person. And so there's always gonna be some problems. I mean, the guy I told you was in class here, when he admitted what his mom did to him, he still has a little bit of problem with writing, but he can do it with either hand now. But that's because he was forced to become a right-handed person, but he was originally a left-handed person.
Can fibers rewire the same way? Because I know how to play the
Yeah,
drums.
if you do it early in life, they'll rewrite themselves.
My feet won't work both, but I know how to play the drums. Well,
You know how to play the drums?
yes, but I learned.
Oh man, you gotta teach me for free. All that money I was spending, I couldn't be, I'm just
But like, I don't think I have ambidextrous. like, I can't write with both hands. and I can't
No,
do
the fact that you could do everything with your hand and your feet at different rhythms tells me a corpus callosum does not exist in you. That's what a good drummer is, because it was never wired that way from the beginning. They can get in front of a drum set, you know, like, who's that? Anyway, the Van Halen is one of my favorite drummers. The whole family is just talented. The drummer, I mean, you got like 20 drums in front of you. I mean, this guy got a hell of a set. And he could just, and his legs going, this leg is going like a different rhythm. This leg is going a different rhythm. And these arms are going everywhere. I'm like, how the hell do you keep track of all that? When I tried it, as soon as I start doing this, all of a sudden I'm following what my leg is doing. Before you know it, it wants to follow my hands. And I mess up the whole rhythm. So as I know, my corpus callosum is just not going to let me suddenly unwire. But he said, the guy who was teaching me, he said, it is possible. But, you know, it's going to take years of practice. I said, I ain't got that kind of money, man. Yeah, I'm done. 1 year of having a good time every afternoon. I was in that in their shop over on Main Street playing the drums. Yes, Karis. What about piano players? Yeah, some of them could be, yeah, because not only are they playing with their hands at different rhythms and their feet is all. You remember that part that they have to step on at the bottom? Yeah, same thing. Yeah. Which one? Practice polyrhythms? I don't even know what that is. Oh man, I don't even know what that is. So I finally gave up, man. So I felt I was wasting my money every afternoon, just paying the man, and when I leave, I still playing the old boom, boom, boom. All right, Rachel. Say that again?
Like if someone writes.
Writes right-handed, but plays left-handed in a sport. Yeah, that's it. Absolute corpus callosum. Yeah, that's why they can do it equally well with no interference whatsoever. Someone who has a corpus callosum, even if you teach them how to do that, there will always be some interference eventually. They'll do it, and all of a sudden they start messing up. That's because of because the fibers now say, "Hey, wait a minute, I want this arm to move," and that messes up your whole rhythm.
Excuse me, doctor.
All right, wait a minute, hang on, right before you, there's someone right before you. Ashley, go ahead. Corpus callosum is usually complete absence in most cases. That's the drummer or pianist. But I've never seen one about partial. I'm sure that there has to be, because you don't have to always be deficient of the whole thing. No, they're not intellectual deficit. It's usually mechanical, because they're trying to do something with the right hand, but that the left side of the brain, and so forth. What? But no, fibers from the right must cross over to the left. That means memory is memory. It's not some motor. But I mean, the motor is memory of how to write the letter A. That means I got to go to my left parietal lobe and figure out how do you write the letter A, and that's why it just comes right out smoothly. You know, but that's you're deriving the memory from that left parietal lobe. All right, Leslie, and then we got to move on.
But if they do the transition very early in life, you don't have any problem on the right.
No, that's what I'm saying. If they do it early in life, the brain will rewire things. The brain is very flexible early in life. That's why if you want to teach a child anything, somewhere between the age of 2 and 6, you can teach the brain almost anything. And it'll just rewire and boom, and it's done perfectly. Yeah, but this is this guy, like he was a grown man, and then his mom is saying, no, you got to use your right hand. And that's hard to do. Start to relearn how to write the letter A and B and C, and here you're a grown man already. Okay. All right, that's dominant parietal lobe. Non-dominant parietal lobe, the two best clues. Apraxia. This is the one aphasia that's not dominant parietal lobe. Apraxia says I put a coin or something in your hand and you can't even tell me what it is. So you put a marble in there or a coin and the person cannot tell you what it is at all. That's apraxia. And then hemi-neglect. Those two tell me for sure is non-dominant parietal lobe. And obviously that's the right side in 99% of people. In the non-dominant parietal lobe, hemi-neglect, remember, if you ask them to draw the clock, they put all the numbers on one side. That's because they don't recognize the left side. You only recognize one side of their body, that's it. Okay? If you ask them, hey, shave your face, they shave only one side of their face. They won't even touch the other side. That's because they don't even recognize that left side of their body is theirs. Here's the danger, folks. What if you leave them alone in the house? The left side of the body can be on fire. They don't see a thing, they don't feel a thing. So anybody who have any neglect, got to be in a nursing home, I have 24-hour care because they cannot care for themselves. They don't even recognize the left side of their body. Okay, so watch out for that. All right, moving on. Thalami. Now we're in the diencephalon, the thalami. Okay, epithalamus, thalamus, hypothalamus, subtype nucleus. Epithalamus, the only nucleus with no known function. It means we've stabbed a lot of people in their epithalamus and nothing has happened yet. So that it's just like the appendix. All these years, you know how many decades they said the appendix has no function. Now all of a sudden they found out it has a function. Huh? That means all those appendices we took out. Oh boy. Okay, now we got a problem. Anyway, same thing here. And whenever they stab mice, whatever mice they use in place of humans, nothing happens. So that means we have no idea what the epithalamus does. All right, that's the only question I've ever seen. Thalamus, all sensory information. Must stop here. All sensory information except olfactory must stop here. If you just remember, lateral is your arms, medial is your legs. There are 12 nuclei. I don't try to memorize them. So like you have VPL, VPM, ventral posterior lateral, ventral posterior medial. Don't do that. As long as it ends in lateral, it came from the arm. As long as it ends in medial, it came from the legs. And it's all sensory information. So questions I see, if I lesion a VPM, what would happen to the person? I said sensory and legs. I just look for legs first in the answers, only 2. And then only 1 is sensory. The other one is motor. In and out in 2 seconds. Okay? Versus trying to memorize every nucleus in the thalamus. Good luck if that's what you're trying to do. Don't do that, folks. It's a waste of time. Yes. If I lesion, yeah, then you would be missing information. Yeah, and all I gotta do is just look for legs, because it says medial, and it's gotta be sensory. That means they would say loss of vibratory sensation from the legs. Yeah, there it is. That's my answer. But you don't need to know everything. So I'm telling you, the easiest way to get these points correct. Remember I told you, I'm not trying to make you a neurologist. If you want to be a neurologist, yeah, later on you can get to know everything, not now. Right now is be organized so you can diagnose any disease they ask you. All right, that's thalamus. A thalamic infarct, some guy's name is on here, but I can't remember his name. A thalamic infarct, all sensory information is lost, but all motor is intact. So it's really easy to diagnose. The person comes in and all sensory information is gone, but everything is moving just fine. Cesar. Was that? Yeah, he can still smell. Olfactory has nothing to do with thalamus. Yeah, very good. All right, that's thalamic infarct. Hypothalamus, we talked about him many times. Remember, controls hunger. Hunger center, lateral. That's where ghrelin goes. Satiety center, medial. That's where leptin goes. Where does ghrelin come from, Miguel? So the walls of the stomach, walls of the stomach. Where does leptin come from, Jess? Yeah, so from the walls of the adipose cells themselves. All right. Controls hunger. Controls menstrual cycle, which we'll be talking about on Tuesday. All right. Because GnRH. Controls temperature. We always talked about this. Anterior cools, posterior warms. So if you want to cool me off, you got to inhibit norepinephrine. If you warm me up, you got to stimulate norepinephrine. And then it controls the stress response. And Chris knows, we'll see, anytime you have stress, the first discharge from your brain is what? Sympathetic or parasympathetic? Parasympathetic sounds better. It's always, remember, 90% of your brain is parasympathetic. All right, parasympathetic first, sympathetic second. When that stress is due to a burn, what kind of ulcer do you call that, Paul? What kind of ulcer do you get when you're a burn patient? Montessori? Curling, curl. Your skin curls when you burn. Due to intracranial pressure, very high. What kind of ulcer? Solange? Now, what's the name of it? What's the name of the ulcers? All right, so Sandra. Cushing's ulcers. Yeah, just like you get Cushing's triad from ICP. All right, but anyway, Anna, you have a question?
Yes, sir. So actually I had two quick questions. Since we're on this topic, what's the relationship between orexin and appetite?
Between what and appetite?
Orexin,
Oh,
O-R-E-X-I-N.
orexin. Orexin is related, also known as hypocretin. Those two are the ones that are responsible for narcolepsy. All right, so it has to do with timing more than anything else, not appetite. I mean, your appetite can be on a timer too. That's why you're more hungry in the morning than you are at night. Yeah, but it's really because it controls pineal, helps to control pineal's timing.
Okay, Mike, quick question on the other things. When we're talking about the dominant lobes, we're talking about musical abilities. Cognitive psychologists have said that, you know, if you teach music early on, you can increase cognition. Is there a particular age that you need to learn an instrument by?
The best time to learn anything, whether it's instrument or otherwise, is between the age of 2 and 6. You can
2 and
teach a
6,
brain
right?
anything. Oh, heck, they learn any instrument. It's so fast, as long as you teach it between the age of 2 and 6. All right, the brain is so plastic, so flexible, it can pick up any pattern. All
Okay,
right,
thank you.
that's why it's hard to teach an adult things, because you missed your window. And now it takes a lot more difficulty. Now you need 2 years of French in high school, and at the end of 2 years, voulez-vous coucher avec moi? Jeez, man, that's all we learned back. I took a whole year just to learn the like 2 or 3 sentences. That's it. Anyway, that's why it's harder, because we missed that window. But teach a child French, 2 to 6. The kid is reading French in a few weeks. That's because he learns the pattern, how to put the sentences together. Boom, he can talk with no problem. Yes.
What year does pruning happen? Is that 8? Is that the same age as 8?
For what?
Pruning, I don't remember.
Pruning means fine tuning.
Yeah.
Yeah, so it's after age 6. That's why, yeah, anytime after age 6, you can fine tune language. That's the remaining 10%. All right, here we go. Stress response, parasympathetic discharge always the first, sympathetic discharge always second. Please, even though every book says a fight or flight, that's the second response. Don't forget that, sympathetic second. Stress ulcers, I explained that. Curling's is when there's a burn, Cushing's when there's a integrated pressure. And then irritable bowel syndrome, I told you, is the same thing. Okay? Acetaminophen works at the level of hypothalamus. We've talked about it a couple of times. First, it cools the body off. That means it stimulates anterior to cool you off, and then it resists fever, so it blocks the posterior. That's why the fever doesn't go back. The problem is acetaminophen, Angie, oxidizes the liver. You oxidize something. Did you give it electrons or snatch electrons? You snatch the electrons, okay? In fact, what acetaminophen does is damage the sulfur groups of the liver. If I want to give the liver back its sulfur groups, what amino acid is rich in sulfur, Angie? Cysteine. Why do you think it's called N-acetylcysteine? See that? When it's just a name and you don't see the physio behind it, it looks like just a name I need to memorize. No, it's the same old stuff again. It's from biochemistry. And for all the physicians I keep hearing, oh, there's no biochemistry on the medical. I say, oh, Lord. That means you're doing a lot of things and you have no idea what it is. Well, there's biochemistry again. All you gotta do is give the liver what it's missing, and what's it do? Regenerate all by itself. That's it. But for this, acetaminophen, if you remember biochemistry, is a 4-hour level that determines what you do. So if they come in before 4 hours, you check the level, and you give activate charcoal, just like any other person, and then keep them there in the ER till the 4-hour mark. At the 4-hour mark, I check the acetaminophen level again. If it's toxic, now I give them an acetylcysteine. If it's normal, send them home. You just gotta remember that 4-hour level determines whether we treat or not. Okay? Subthalamic nucleus, the final relay stage of coordinating fine motor movements. By lesion your subthalamic nucleus, you get bulismus or hemibulismus. What is bulismus? When your arm flings out to one side, or your body is thrown to one side. That's hemibulismus. Bulismus is when your whole body is thrown to one side. All you gotta do is look at the mosh pits at rock concerts. That's bulismus. The way they turn themselves around like that looks like bulismus to me. Anyway, that's what bulismus actually looks like. But that's not what they're doing. All right, hemibulismus is when half your body goes flinging out. Now, my partner took care of a lot of kids. His big interest was Down syndrome and cerebral palsy, so I got to see a lot of this stuff. So hemipalismus, the warning here is to the mother. Your child has hemipalismus. The arm can go out at any time. Don't ever sit your child next to a stranger and walk away. If that thing goes off, you got a problem. So let's say it's a hot summer day and she's walking through the mall with her child and she says, oh, ice cream. She says, Johnny, stay here for a second. I'll be right back. We'll go right over here and get you some ice cream. So while she's going over there to get some ice cream, here comes this biker. Got open leather vest. And he's got a tattoo on his arm. And it just says, die. That's it. Nothing else, just die. You're like, ooh, okay, it's a dude. So he gets some ice cream too. So he's thinking he's gonna enjoy this ice cream. He can just, oh man, he's just looking at it. Got his tongue right next to it. And then all of a sudden, hemipalismus goes off. The child, ice cream. Okay, come on, son, get up. We're gonna have to fight this out right now. Now this guy's about to pummel your son. Here come mommy. Oh, please don't hurt my child. He's got hemipalismus. Hell, he's about to have hemi neglect. Get him up right now. Because you can't teach neurology to a stranger when your son just slapped him in the face for no reason and try to say, oh, that was just an accident. No, to him, it's fighting. Let's go fight. You know, so never sit that kid next to a stranger and walk away. Because if that thing goes off, he's slapping somebody. And that person's gonna be real mad that he just got slapped. All right, anyways, that's subthalamic nucleus. Here's internal capsule. I want you to see this picture because internal capsule, all right? You got the medial wall. The medial wall is gonna be, let me see, at the top, putamen and thalamus. Let's see, make sure again. I'm just trying to, oh no, caudate and thalamus. And then the lateral wall is the rest of basal ganglia. So you got that part right. All right, putamen, and then you got subthalamic nucleus under all of that. Again, that's just memorization. All right, let's keep going through it. Substantia nigra initiates movements. Substantia nigra sends fibers with dopamine to the basal ganglia. Substantia nigra initiates the movement, basal ganglia carries out the movement. That's why I say basal ganglia controls gross motor. But to initiate it, substantia nigra's got to fire. And then above it is a cortex. So you think of a movement, come to substantia nigra, okay, initiate it. So let's say I tell myself, I want to move my right arm. Now this is happening in fractions of a second. You don't even think about it. My brain says, I want to move my right arm and put it over the chair like this. So cortex initiates the thought, comes down to substantia nigra, who initiates the movement, and then basically it takes over and does the rest. Okay, so think about then in Parkinson's. Look at the inhibitory signals, acetylcholine and GABA. That means after you do the movement, the basal ganglia sends acetylcholine and GABA back to the substantia nigra and says, hey, okay, we're done. We've already done the movement. Think about Parkinson's now. If you don't have the dopamine telling you to initiate, why do you think they sit there with a mask-like faces? They don't want to initiate an expression. Why do you think they have shuffling gait? You don't want to initiate walking. Why do you think they have pill rolling tremor? That means that's actually the supinator and the pronator trying to stop each other from initiating a movement. All right. Fenestrating gait. Ooh, boy, that's the one that scares me. Fenestrating gait is normally if I trip over something, what do? Put your arms out, grab something and get yourself straight back up, right? Parkinson's doesn't want to do that. He does not want to initiate a motion to put himself back upright. So if he trips over something, he just starts shuffling real fast as he can. Well, as fast as he can, it's not that fast, but that's what he's doing. He's just shuffling like this as fast as he can and hoping that the velocity will somehow bring it back up like that. It ain't gonna happen for anybody, even if you're normal. But that's his thinking because he doesn't want to put his arm out. And for that reason, folks, he's down like this. He will ram his head into the wall on the other side. Number one cause of death, intracerebral hemorrhage. They ram their heads into walls all the time. Fenestrating gait is dangerous. So that means the person who's got Parkinson's in nursing home, you'll see they got a belt around him. You see him shuffling real fast, you better grab that belt because he's about to run his head into the wall and die, but you'll be liable for it. Okay, because you're supposed to know that's what happens. All right, so anyway, that's substantia nigra. But this way, when we're treating Parkinson's, what do? Give him the dopamine that he's missing, or see that? enhanced GABA, or anticholinergics. Those are all the treatments for Parkinson's. But notice how it follows physiology. Before you start learning all this management stuff, because you don't see, all they're doing is mimicking what's here. Okay? They had to figure this out and say, okay, I need a drug that can do this, and that should make the patient better. Okay? So Parkinson's disease, loss of dopamine fibers from substantia nigra to the striatum, which is called putamen. You're unable to initiate activity. So I gave you the list of all these things that have to do with problems initiating something. Remember autonomic dysfunction? They can't even initiate the autonomic reflex to get their blood pressure back up. That's what shy Drager is. Get up from a sitting position, wham, plant their face in the ground. Real dangerous. Okay. Treatment, L-DOPA and then carbidopa. Carbidopa inhibits the inhibits the breakdown of the L-DOPA. That way, more of it gets to the brain. That's first line drug. Still remains first line drug. Ibuprofen can also be used, but it has more side effects. But we use carbergoline and bromocriptine to treat for pituitary tumors, which I already spoke on. Carbergoline just beat out bromocriptine, so that's the drug of choice for that. Amantadine was first made for influenza because it inhibits uncoating. But then they found out it promotes the release of dopamine and blocks MAO from breaking it down, so that helps out. But notice he's like third on the list because he's not as reliable, because that's not his main action. Selagiline, the only MAO-B, remember B for brain, can block MAO from breaking down dopamine. Any questions on Parkinson's disease and how to treat it? All right, very good. Movement disorders in middle-aged people. Again, you've seen this before. I just repeated it here, so remember it. Huntington's is 90%. Wilson's was a 10%. Remember, Huntington's is also a dominant. Wilson is also recessive. Trinucleotide repeats in Huntington's, none on Wilson's. Caudate nucleus involved in Huntington's, then it's lenticular over here in Wilson's. You have anticipation with Huntington's, but not with Wilson's. You have decreased GABA fibers, and then treating with dopamine blockers. What was the number one cause of death in Huntington's, Amy? Suicide, remember, because there's really no treatment for the disease. So when they find out that the drug you give them only treats symptoms, but not the disease, they just say, forget it. Okay, so that's why you got to really talk to them, try to keep their spirits up. With Wilson's disease, remember, treat with penicillamine. You got Kaiser-Fleischer rings, lenticular nucleus involved. So that's how they get movement disorders, and then liver failure. They tend to have psychiatric problems before they get the liver problems. Any questions on these two? Again, you heard all this before in biochemistry. Internal capsule, all motor fibers going in and out of your brain goes through here. So if you have an internal capsule stroke or bleed, you lose all motor function, but your sensory is still intact because it went to the thalamus. So I don't think anybody has their name on this one, but most common cause of this, they call it lenticular striate arteries. They're the tiniest arteries to your brain. So hypertension is the most common cause of this. Okay, lacunar hemorrhages. You lose all motor function. This is called truly trapped, locked in syndrome. You're locked into your body. There's no more motor activity, but your senses are still working. Internal capsule. Any questions now? Go. Reticular activating system, RAS system. That's different from the RAAS system, which we did in low volume state. But this is reticular activating system. This is what wakes you up every morning. Next, this is what helps you focus and get things done. So what disease has a trouble with focus? 3. ADD and ADHD. This is where the problem's at. Look at this. Reticular activating system requires norepinephrine and serotonin. Now you know why amphetamines work very well for them. Now you know why drinking caffeine and drinking all these Red Bull and everything treats your ADD. Because look at that, SAC-MP, second messenger, no surprise. So a lot of adults, we thought you outgrow ADHD in childhood. Now they find out only 70% outgrow it, 30% continue into adulthood with the same problem. But we like SSRIs, treating them, now you see why. Okay? Your reticular activating system has a long refractive period first thing in the morning. A long absolute refractive period. So that means when you wake up in the morning, notice why you kind of sit there. Yeah, contemplate. Should I really get out of bed or should I just lay back down? You realize you're not really with it yet. That's because your RES is not quite awake. right? Think about, yeah, especially this morning, especially when it's so cold outside. Think about the elderly. This is why they break their hips in the morning. Imagine you just woke up, your RS is not up yet, and then you wake up, you start walking towards the bathroom. All of a sudden you trip over a tiny cord. How'd that happen? You trip over a pencil. How'd that happen? That's because your RS is not up yet. That's all for elderly people. What do? We tell them, sit by the side of the bed for 5 minutes before you walk to that bathroom every morning. Because we know they break too many hips, okay? Or late at night when they get up to go pee, break a hip, because RS didn't wake up so fast. All right, for those who have trouble getting a bathroom, what do? Put the bathroom right there. Because if you make them want it, they're gonna crack the hip. Okay, so it has a long ARP, which gets even more prominent as you get older. So the key thing is sit by the side of the bed. We say wait a good 5 minutes and then go pee. But if they can't hold it, see, then you gotta make sure they get bedside commode. Okay, so your RAS system has a long ARP. So they go with sleep waves. You and I, when we go to sleep, these are the waves we experience when we fall asleep. First, you have a sleep latency. Not sleep latency, REM latency. To go into your first REM, 60 to 90 minutes before anybody goes into their first REM. Who has a disease where they have no latency? Cares. Narcolepsy. That's what you see in a sleep study in case they ever ask you, how do you diagnose it? Sleep study, straight in. As soon as they fall asleep, they're REM already. Normal person can't do that, but narcolepsy can do it. All right, so we have a REM latency of 60 to 90 minutes. You go into REM 3 to 5 times every night, and you wake up out of REM every morning. Cataplex is part of narcolepsy, yeah, they go right into REM, okay? You wake up out of REM, and that's why you can always remember your last dream, because we form memory during REM. That's because during REM, it's controlled by parasympathetic. What's the neurotransmitter for parasympathetic, Chris, for the sleep? Huh? Neurotransmitter for parasympathetic is cortisol. All right, Adnan. He was praying that you got it right. I got it. All right, Gloria. It's called acetylcholine. You guys have heard it 1,000 times already. All right. So acetylcholine, however, remember, controls craniosacral. That means when you hit REM, your brain starts working, firing off signals. If it's good signals, you call it a dream. If it's bad signals, you call it a nightmare. Yeah? But at the same time, the little belt starts stirring. That's why you get an erection if you're a male. That's why you get vaginal lubrication if you're female. So that's why if your time is just right, we can work this out. This is why husbands, you learn, let your wife go to sleep first. For about an hour and a half. Baby up. You know, damn well say it up. But I know what happens in 90 minutes. Okay, hey, it works. And just a little tip to the husbands that when you become a husband, is that you gotta play whatever game you play to get some. This is how you do it. You gotta time it just right. All right, but anyway, because it's happened to both of you. All of a sudden you got erection, she's got vaginal lubrication. So that means if you're both up at the same time, it's on. All right, this is why a lot of couples engage in, especially busy couples, professional couples, engage in early morning sex because they're both ready. No foreplay, no flowers, no poetry, just go right at it. My job is to educate you guys. I know it sounds crazy, but that is the truth. You know, professional people, this is one of the things they use to keep their sex life going. Because why? During the evening, both people come home, they're tired. Ain't no sex at night. They just do it in the morning. Okay? That way you don't have to do any of the foreplay stuff. All right, anyway. Because during REM, you form memory. If somebody has any strange behavior during their sleep and can remember it, that's how you know it's REM sleep disorder. See that? One little clue is all I need. If he can remember anything, that's REM sleep disorder. Non-REM, there is no memory. The wife will be telling you, he keeps doing this and doing that and doing that. And he said, I don't know, dog. I don't know what happens. That's how you know it's non-REM sleep disorder. Okay, because he has no memory of it whatsoever. Any questions on that? All right. Sleep waves, let's go through it. The mnemonic I use, BAT-D. So B-A-T, then D, and then REM, BAT-D. Theta waves, when you're wide awake with your eyes open, like now, hopefully. Theta waves. Alpha waves, eyes are closed, but you're not asleep. It's how you can hear the train going by, even though you got your eyes closed, but you can hear that train. That's because you're in alpha. Okay, or you can hear people outside the window. That's alpha. Your eyes are closed, but you're not asleep yet. Theta is called light sleep. Theta has stage 1, 2, and 3. And stage 2 is the one they're always going to ask about. That's when you see sleep spindles and K complexes. That's the one they always ask about. What stage of sleep do you see sleep spindles or K complexes? Only the theta waves, stage 2. And then stage 4, D for delta, deep sleep. Stage 4 is deep sleep. That's where delta waves occur. Deep sleep is where you have the most motor activity. So if I hear about a lot of motor activity going on, I can tell you it's going on during delta waves. And then REM is the most restful sleep. And if it's most restful, restful sounds parasympathetic. That's how to remember that. Remember, rest and digest, parasympathetic. So when I say motor activity, see that? Like these things. Rather than trying to memorize them, somnambulism, sleepwalking. That's a lot of motor activity. You're walking down the street. Bruxism, teeth going. There's a lot of motor activity. But the person has no idea he's even doing it. Okay, restless leg syndrome, night terrors. They scream, shout, throw their hands, all of it. So you have to tell them off. Don't get in his face when he's got night terrors. They'll slap you 3, 4 times. But remember, he has no memory that he's done that. And so the mom will get all mad, but the kid has no memory of ever hitting his mom. Okay, so you just tell him, leave him alone, you'll fall right back to sleep. Okay, don't get in his way. Night terrors doesn't kill or hurt any child. Somnambulism, sleepwalking can hurt people because if you walk outside, you can walk right into traffic. Okay, and get yourself killed. So then we try to do something about it. REM sleep, REM latency for first 1 to 2 hours, controlled by acetylcholine, dreams, nightmares, depends on what kind of thoughts you're having. We go to REM 3 to 5 times per night. And then you have decreased REM if you're on a benzo or barbiturate or even SSRIs. If I put you on benzo or a barbiturate, you get what they call REM rebound. Okay, that means I won't let you go down to REM. That means you stay up here in delta and still good sleep. That's why you feel like, hey, I slept real good last night. And then before you know it, now you're hooked on Ambien or whatever else you're taking. Okay, that's how they become addicted. But you know, they've done studies on people who take these sleeping pills. They say, okay, how'd you sleep like that? Oh, I slept real good. I feel better. And so what they do, they have them do some tasks after they wake up. Since you say you feel better, man, they score terribly. That's because you never went into REM. That's why when I stop it, you go into REM. That's REM rebound. So when you stop these drugs, now we see with SSRIs, they start complaining about all these colorful dreams that they're having. All of a sudden, it's because you just stopped the drug. Okay, so that's why they say now withdraw slowly. They call it antidepressant AWS. Antidepressant withdrawal syndrome. That's the AWS. That's what they're calling it. So now they know you have to withdraw every drug slowly. Don't withdraw quickly. We thought you could do it. That used to be the recommendation. Just stop it anytime you want. Now we know you don't want to do that. You're going to get REM rebound. All right, attention deficit disorder, ADD or ADHD, RAS is not working, poor attention and focus. They can't finish anything, but they're restless. They shift around in their seat. They never seem to complete their tasks. They don't bring in their homework. I mean, everything. Methylphenidate for children, SSRIs for adults. And then here's the backup drugs we already talked about several times. All right, Karis, you first. When you're meditating, if you're wide awake, yes. If your eyes are open, if your eyes are closed, then it's alpha. Yep. All right, Adam, you have a question?
Yes, sir. So, 2 questions. So we're talking about REM. If you give somebody Benadryl that has anticholinergic effect, so any anticholinergic is gonna decrease REM, right?
Right. Any anticholinergic will make you sleepy, but it's going to decrease REM. Because anticholinergic is still sympathetic. That means it's going to keep you from going too deep. That means you can't get into REM. But you feel like you had a great sleep,
right?
But you didn't have any REM. All right, go ahead.
Then how would you recommend getting better REM sleep?
Better REM sleep is just sleep hygiene. That means fall asleep at the same time, no TV or computer in the room, that kind of stuff. Or music, I love music. You know, just soft music in the background, I'm going real fast. All right, yeah, because music is okay, but not TV. And it's gotta be music where you're not hearing the words. If the words are playing, walking along the beach with the one I love, hell, you're walking along the beach now. All right, you actually start visualizing yourself walking along the beach. Well, that means your mind is still awake. Whereas if it's just, you know, classic music, or the station now called Calm, you just play sound waves for it, push you right to sleep. Okay?
And my other
Just hear
question,
the
sir,
waves. Go ahead.
my other question was regarding the basal ganglia. Since
All right,
basal
basal
ganglia,
ganglia.
right, since it was responsible for initiating movement and fine tuning movements, quarterbacks do these trainings of repetitive throwing. What's the connection between like muscle memory and basal ganglia and like fine tuning your coordination?
Now, hang on, substantia nigra initiates the movement, basal ganglia carries out the movement, so we say gross motor.
Okay.
Right? Muscle memory just says, if you keep doing the same thing all the time, the muscles anticipate what you're gonna be doing. Remember like the weightlifter I told you about? The cross bridges will be made for him. They just anticipate you keep lifting an average of 80 pounds, cross bridges for 80 pounds are made already. So that's muscle memory. It remembers what you're doing all the time. If you're doing it long enough, it then starts to anticipate what you're doing.
But
Okay,
can
what was the other
decision making be made
question?
faster if you repeat a task?
What's that?
Can decision making be made faster if you repeat a task?
Can decision making be made faster if what?
If you're doing like practice or repeating a particular set of movements.
Oh, yeah, if you do the same thing and you keep practicing every day, then that means decision making can go faster. Think about basketball. That's why they practice every day. All right, okay, you got a guy who's been cutting here, you want the ball going to him. That means you can anticipate he's gonna be cutting, you got the ball already thrown to him before he gets there. Think about in football, you know, like Tom Brady. Remember, he's gotta know, he knows what the wide receiver is gonna do. The ball is out in front of him before he even gets there. So yes, you can train your muscles to do that for you.
But
All right, Mabel?
I
Go
just
ahead.
wanted to clarify
Sir.
something.
Wait a minute, okay. Adam,
No, so when we say that, so it does not have any relationship with the basal ganglia or.
no, it has nothing to do with
nigra.
basal ganglia,
That's
that's
just
muscle memory.
then, right?
That's muscle
Okay,
memory,
got
you
it.
can train
Okay.
that. All right, Mabel, you go now.
Sir, please, the place you talked about theta wave. Can I
What?
see this? There's a place you talked about the theta wave, right? You're talking about sleep or disorders?
Oh, theta waves?
Yeah, can I see the slide, please?
You don't have it in your notes?
I didn't see it in my notes. Maybe I have different notes or something.
Oh, no, it should be in your notes.
Okay, thank you, sir. I'm good.
Was that? It's deleted? Wow, oh, just the beta wave part is deleted.
But it has a spindle part, but just not the headache.
Oh, okay. Oh, that's first time somebody pointed out. Okay, good. Make sure you put that in the website so we can get that corrected. Oh, all right. I'm not even sure what I just hit. Hang on. Anybody know what I just hit? Okay, hang on. I know. Do I have to click this one? What do I do? This one? I don't know what I clicked. So anybody know?
You can hit Control Z.
Out tab? What's out tab?
Escape.
Escape?
Control
Just hit
Control
escape.
Z.
Oh, I didn't hit it hard enough. I thought I hit it. I guess I didn't hit it hard enough. Okay. All right, let's go. Let's move on, folks. So let me see right there. Okay, ADD and ADHD, so everybody should be clear on that. Now, I'm coming in with the pathways. Any questions? We've done structures, now pathways going up and out. So I'm gonna come down, and I'm gonna come up to complete the whole thing. Any questions on any structure? Okay, because I've tried to go in order. We worked our way down. Now I'm gonna do the pathways. Yes. No, it's just that you can have beta waves when you're in REM, but REM is rapid eye movement. That's much more diagnostic of it. Yeah, because in REM, it's almost like you're wide awake, but it's only your eyes are fluttering the whole time. That's why they say it can have beta waves in there too. Yes.
Yeah, so REM is like a lot of brain activity, right?
Yeah.
So, sounds like recent verbs, brain cells and stuff can suppress REM, so in a sense, you're suppressing the brain activity, right?
Right.
But you still sleep, so is it correct to say that the sleep cycle waves that are more active, you're suppressing them, but you're sleeping, so
You're sleeping well, but it won't let you go all the way down to REM. That's the only problem. But-
that's the only sleeping that's more active, right?
Right, so up here where you're more active, still be there.
Okay.
And but it allows you to come all the way down to delta. And
Okay.
that's why the person still feels well rested at the end, in the next day. All right, we're gonna do corticospinal tract. This is called upper motor neuron. Okay? Upper motor neuron. It has 3 divisions. First one is corticospinal. Corticospinal goes down the entire spinal cord. Look at that, inhibits extension of the upper and lower extremities. Why is that? Ashley wants to know. That's because Ashley, when you move your extremities, is mostly flexion. Flexion is what allows you to do the most movement. So, well, in order to do that, you gotta inhibit extension. Extension is the default movement, folks. You don't need anything for that. That's why when you die, where are you? Fully extended. Because there's no more brain signal to stop it. All right, just remember, extension is a default movement for your body. So corticospinal tract has to inhibit that in order to allow you to flex. Okay, reach out for something, grab something. That's all flexion activity. Okay, that's corticospinal tract. Then there's one called corticorubral. That means for the cortex or red nucleus. The red nucleus is up in the midbrain. Okay, and he sends another fiber called rubrospinal. That means for red nucleus to the spinal cord, but only for the upper extremity. It flexes your upper extremity. This is why you can do so much more with your upper extremity than you can with the lower extremities. Because you got this extra signal that allows you to flex more. That's why expressive dancing is done more with the hands than any other part of your body. Simply because it can. Okay? So red nucleus flexes the upper extremity. And then rubospinal is the end of the pathway. Then the last one we talked about before was the corticobulbar. That means from the cortex to the cranial nerves. That when you start thinking about something, the cranial nerves can act. Like when you start thinking about food, all of a sudden the vagus starts firing, your gut starts working already before you even eat. So corticospinal tract has 3 divisions. And you want to know what each division does. The major one is corticospinal because it goes from the cortex to the spinal cord. Any questions on that? How do I know you got a corticospinal tract damage? Okay, there's the 3 divisions we just talked about. Here's how you know. Spasticity. Why is that? Because every time you try to flex, it wants to extend. And that's why you see this whole thing. Hey, wait a minute. It won't let you just flex. Extension wants to go. Okay, that's what spasticity. Babinski. What happens when you stroke underneath the toes? It's supposed to curl in like that. That's flexion. And instead, extension. Corticospinal tract is gone. See? Hyperreflexion. Maybe you never noticed. All your reflexes are extensive moves. Extension moves. Look at that. So that means with corticospinal tract out, that means extension is now even more violent. That's hyperreflexion. That's why I say, folks, know the basic physiologists. Even though it's 4 words, you don't have to memorize them. As long as you see these are just 4 expressions of the same action, then they can use any one they want and you'll still see the same thing. Corticospinal tract is out. And then clonus. Clonus, if I tap the bottom of your foot, all of a sudden it starts extending. See that? And that's why this is doing that flapping motion. Okay, clonus. But the underlying theme is you lost the ability to inhibit extension. All 4 words mean the same thing. Corticospinal tract, diseases. So, well, let me follow the pathway first. Fibers originate from the frontal lobes, like I've explained to you. That's called a precentral gyrus. They descend through the internal capsule, like I showed you, and cross at the medullary pyramids. That means the actual crossing will be at the medullary pyramids. Now the right is on the left, and the left is on the right. Everybody understand that? This is important. Why? This is how I know when somebody has a brain lesion, because everything is opposite to the lesion. So you come in and tell me your left side can't move. I'll tell you the problem is on the right side of your brain. Everybody follow? I use upper motor neuron signs to tell me it's a CNS lesion. Okay, that's how I know it's not a spinal cord lesion. That means you can at least eliminate the 2 or 3 answers that came from the spinal cord. It cannot be those. Your whole side is out. You can only do that from the brain. Okay? All right, so corticospinal tract. Pathology. atonic seizures, I already explained earlier. They drop to the ground like a wet noodle. And of course, again, phenobarbital for children, phenytoin for adults. So in this disease, depolarization went across the entire frontal cortex, so everything just dropped. And of course, when the seizure's over, they get right back up. All right, B12 deficiency we've talked about, right? B12 is the cofactor for what two enzymes in your body, Mabel?
He says so
Right,
for what?
Cynthia?
So what do you ask, sir? I know the answer. What's the question, please?
Cynthia? Are you guys just hiding from me or what?
So I asked the
Straight
question,
underneath
right?
the bed? No, not listen anymore? John Cisco?
That be
Oh, man.
methylmalonic acid and something starts with an H too.
John, you guys just not hear me or what? I don't get it. What thing is that? What? Wait a minute. So,
Can you not hear
John,
me?
can you hear me?
I can hear you. Can you hear me?
He can't
John?
hear. He's not
This is
hearing
mine.
anybody.
It's not my sound. Acuna, can you hear me?
Hello? Yes, I can hear you.
Hello.
Hello, sir. Can you hear me, sir?
Those are pretty high.
Can you
Can
hear
you
me,
hear me?
doctor?
Yeah, okay. Let me see.
Can you hear me, sir?
Hello, what'd you say? Hello? No, the sound is coming. out.
Hello, can anybody hear me?
Open the chat. Oh. Oh, is it better now? Oh, we can now hear you? Oh, okay, now we can hear you. Okay.
I'm not
I'll try to
hearing
make
him.
sure this stays close to my lips. Maybe that's what's going on.
I'm not hearing him. What is
All
going
right.
on?
Yes, Mabel, we can hear you. Oh, Mabel, can you hear me?
Yeah.
Yes, yeah, what was the question? You asked me a question, right?
My volume is off? Yeah, see, my volume is high here. Okay, sometimes that does that. I was wondering why nobody was answering. Okay. All right, hang on. Let me try to figure out what that, because no, something's gone off here. Usually I gotta experiment with something and get the, hello? Can you guys hear me now?
Yes, we can hear you.
No. Now they're all saying yes. No, I just have to change mics on here. Okay.
Can
Yeah,
you
'cause
hear us?
normally Mabel's the only one that can't hear me. That time 4 people didn't hear me. All
Can you
right.
hear us? Hello?
Oh, we just could not hear them. Okay, that's why. All right, John Cisco.
Yes. Can you hear me?
The speakers must be out for that side. They can't hear any of
Yeah,
us.
let me see. All right, John, say something.
Hello.
No, my speaker's not muted right here. It's not muted. Oh, wait a minute. You're right. Maybe, hang on. That's down here somewhere. Yeah. Oh, now I forgot how, okay, I think I gotta stop share for a second. There was a way to go in, darn it. I know, oh man, let me see. There was a way to get it to be louder. I might have clicked it and silenced it. Hang on. Oh. Can you guys hear me? Adonis, can you hear me?
Yeah,
Leslie?
Yes, doctor, I can hear you.
Yes, we can hear you.
I
doctor.
cannot hear them. Okay. Now, I'm not sure. All right, let's see. Okay, share screen.
Maybe his
All right, but I cannot hear them. What?
Does the keyboard work?
Yeah, keyboard works. What do you,
The keyboard is all you need.
for some reason, I forgot what I did the last time that happened. Yeah, I've got it real loud. They can hear me. My voice is loud. Yeah, I can see it, tell right here, but I cannot hear them. All right, somebody online say something. Say something. Leslie, can you say something?
Hello?
Hello?
Hi,
Dr.
Francis.
Hey.
All right, I'm gonna go out. I'm just gonna reset it. I was trying not to
Hey.
restart it, but we'll have to reset it. Something has,
Is anybody
I
hearing
don't know
me
what I
here?
did, but.
Yes, Mayor Bell, we
Ah, this
can't
is
hear
the
you.
same.
It's not us.
Mabel, only Dr.
Yes,
Francis
something
cannot
on
hear it.
Zoom. So let me see.
Oh, please.
All right, end it.